we can convey to them our differentials more accurately. So to take you through today's sessions, the first session is going to be on assessment of dry eyes and dry mouth and salivary gland biopsy. And you know Dr. Sandhya, she has actually been leading the Jogren's work in India, and she is also one of the conveners of SIG for Jogren's and some of the big international data collections as well. Dr. Funny will take us through the muscle biopsy. You know that he is Associate Professor at the Department of Clinical Immunology and Rheumatology at NIMS. And he is one person who is actually very much interested in muscle diseases, and he is very widely published in this area. Dr. Partha Gorai, he is, I must thank Dr. Partha Gorai for taking up this session today. He is a neurologist, and I'm told that he is very good in nerve biopsies. So let's hear from him what he has to teach us today. Dr. Kunal is recently moved to SGPGI as assistant professor, and he is also he's a very enthusiastic teacher, I would say, that, and I look forward to his session when he teaches about the skin biopsies. And Dr. Shankar is, so the nephrologists are holding currently the domain for kidney biopsies, but in some centers the interventional radiologists are actually taking lead in doing the kidney biopsies. So soon, with the help of our interventional radiologists, we could probably take over kidney biopsies rather than sending it to nephrology. And sometimes it happens that we are not in sync with the nephrology, or our patients have to go to a different setup for a kidney biopsy. So if we have an interventional radiologist, and with them we can do our kidney biopsies, it will really be wonderful. And lastly, me, I work at St. John's, and I've been there for the last 20 years. And I hope we all have a very fruitful session today. So the key theme of any workshop is to get involved in the sessions. So I hope that all of you will stop us halfway anytime and ask us questions so that we can all grow together. Thank you. Let me start with the Jogren session. Dr. Sandhya, could you please?
ACR-EULAR classification criteria for primary Sjogren's syndrome 2016. I'm sure most of you would have come across this. So this criteria, we should remember that there is no diagnostic criteria for Sjogren's syndrome. In the absence of diagnostic criteria, broad principles of diagnosis are derived from the classification criteria. So in this criteria, you can see there are 5 criteria items, and the maximum score is given to, maximum weightage is given to antibody positivity and minor salivary gland biopsy, which is positive if the focus score is more than 1 foci per 4 mm square. So this has the maximum weightage. We know that only 60% up to 60 to 70% of patients with Sjogren's have antibody positivity. So if we need to make a diagnosis, in those who are seronegative, we need to rely on a minor salivary gland biopsy. The other items here are to demonstrate, so the patient may be complaining of sicca symptoms. We need to demonstrate objectively that there is gland hypofunction is present. How do we do that? For eyes, there are 2 items here. One is ocular staining score, which is done by an ophthalmologist because this requires slit lamp. But Shermer test is one which the rheumatologist can do. So to demonstrate oral sicca, we have unstimulated whole salivary flow rate, and this is again something which we can do. So the essence of today's talk will be on minor salivary gland biopsy, followed by oral and ocular test, which can be done bedside or in the clinic. So first, let us talk about what are these minor salivary glands. So minor soft and hard palate and floor of mouth. We are most interested in the labial mucosa, especially the lower lip, because that is easily accessible and can be manipulated. Now, so the first thing what I would like to say is, first we need to identify which are those minor salivary glands in the lower lip. So what I would ask is, use your tongue and press against your lower lip. Can you feel that mounds of tissue? Or is it in the sides? So when you move from the center of the lower lip towards the lateral side, where do you feel maximum concentration of those mounds? Where do you feel? Yeah, so it is more on the lateral aspect. Good. So that is where you see. So if you see, I do not know how clearly you can appreciate it here. You can see it as glands. Now when you prepare for the minor salivary gland biopsy, what do you require? So the minimum requirements for a lip biopsy set, because we tell our staff to keep this handy, you need a drape, you need gauze, you need scalpel, the size of the blades can be 11, 13 or 15, and you need a blunt forceps. Lignocaine spray 10%, you need a 1 ml syringe, and with a small needle, 27, anything from 27 to 30 gauge needle. Injection lignocaine with epinephrine, you can even use plain lignocaine, betadine for cleaning, and the 10% formalin bottle in which we have to send the samples. So first you need to explain the procedure to the patient, get a consent. Then let us talk about posturing the patient. So if you look at videos that is available in YouTube and mainly from the West, they do this procedure in a sitting position and the clinician stands in front of the patient. What we generally do here is, the patient is in supine position. I find that the patient is more relaxed that way. So patient is in supine position, the neck is slightly extended and the clinician will stand at the head end. So based on your height, you can adjust the height of the table on which the patient is lying supine. So that makes it easy, so you do not have to crouch forward. So first what you do, so this is a patient, and incidentally this patient had ILD, antibody negative, so she had a LIP pattern of ILD, that is why we had to do the biopsy to make a diagnosis. So you can see she's on oxygen and this procedure was done bedside. So first what we do is, you give a lignocaine 10% spray. So that way that lower lip is anesthetized and it is easy to do the procedure. Then second, you clean and drape. So you clean the lower lip surrounding area and you drape. Then, like I said, you need to identify the salivary glands. What you can do is apply pressure using fingers over the skin side of the lip. So from the lower part of the lip, if you apply pressure, you can see these glands very easily. Then, next step is to administer the local. So where you have identified the glands, you inject 2% lignocaine and epinephrine. You need only 0.4 to 0.6 cc. That is all that would be required. Okay. Like I said, this is minimally invasive sutureless. So where you have identified the glands, just nick with the scalpel, just nick on top and the glands will pop out. It is that easy. And you need to, so what you can see when the glands are popping out, there is a loose fibrous connective tissue that you just need to dissect. And then you cut the glands and you can put it in formalin. So the other thing is, like the previous technique was to do a 1 to 1.5 centimeter incision. So sometimes we may have to do that in some cases where you are not getting enough glands. So for that, there are some suggestions. So I would like to ask you, what do you think is a better way in case where you have to extend the incision or you want to follow the old technique? So you have a vertical option of vertical or a horizontal incision. So what would you prefer to do? Vertical. Why vertical?
A bigger area like if you give the horizontal.
Okay. So that is the correct answer. So vertical incision, in this they did an RCT and they found that vertical incision is associated with less pain, less swelling, less scar formation and less difficulty in eating. But there is a very important reason why we should avoid the horizontal incision. Okay? Yeah. So the reason is, you can see there is a branch of the mental nerve. Okay? So if this runs vertically, now if you were to make a horizontal incision, you would be cutting across the mental nerve, and this results in permanent paresthesia. So this is the reason why, this is one very important reason why we need to avoid doing the horizontal incision. Anyway, I think it should not come to that. We have to follow the minimal invasive sutureless technique. Okay. The other modification technique that has been used is using a chelation clamp. Now this is available with our ophthalmology colleagues. So this is easy in the sense that you don't have to apply pressure with your fingers continuously to find the glands, and your hands will be free. So that is one advantage of using a calacion clamp. So all the other process remains the same. After you give the local, you insert this calacion clamp, and then you can identify the glands very easily, and you can make the hit, and the remaining process is same. So this is, I find it easy in some cases to use the calacion clamp because your hands are free. So this is another advantage. So this paper is from BMJ Innovations 2021. So somebody has devised something very similar to a calacion clamp. So you can see how they have used the clamp, and these are the steps that they follow. The steps, as I mentioned earlier, you apply the local, you position the clamp, you have disinfected, you see the size of the incision is very, very superficial, only 3 millimeter incision, and then you take out the glands, and then you can see at the end of it, just look at the figure number 7. So no stitches are required because the incision is so small. So then how do we check the adequacy? How many glands should we remove? So the gland tissue should include at least 4 small salivary glands. This will be the size. So this will just pop out. Like I said, when you nick it, this glands will pop out. You need to slowly dissect the tissue and find the glands. So I should be showing the video where you can see how the dissection is done. So the minimal glands of a series should be 8 millimeters square. If the glands are too small, 6 glands should be taken. So these are the size of the glands. And when you put it in formalin, if you see that all the glands are floating, then they are probably not glands, that is fat. So generally the glands should sink. So that is one very important thing to ensure that you have taken enough and adequate sample. Now, what is the aftercare? What would you advise the patients at the end of the procedure? First, the patients should be on a soft diet. They should avoid hard, spicy food for a couple of days, and they can use a betadine mouthwash. Okay, the chance of infection is very minimal. Antibiotics are not required. We do not routinely prescribe antibiotics. Now, what are the complications that you can expect? Now, this is from a large single-center study, and they have again used a minimal invasive technique, and they, in 99.2% cases, the samples were adequate. Transient adverse events were seen in 64, 40 had paresthesia lasting less than 7 days, 17 paresthesias lasting less than 14 days, 27 cases of local swelling, and 8 cases of external hematoma. Now, in case you have to extend the suture, like I said in this case, then we need to use you have to suture with any absorbable suture. So you can use 5-0 Vicryl, that is what is generally used, or you can use silk, or you can use chromogut. So these are the sutures that can be used, but like I said, we have stopped doing the suture technique. Now, the most important part is not actually taking out the biopsy, is actually having a good pathologist to look at the biopsy. So this is very, very important. So if you are planning to do, first thing, you should have a talk with your pathologist, and there is a paper in ARD where the very details of how the biopsy has to be reported is there. So I can circulate that paper. So I think we should have a talk with the pathologist and engage them in this process. So this is a pictorial representation of what a normal salivary lobule looks like. So we have the normal SNR lobule, and what you can see in black circles, that is the duct, and the red is the blood vessel. So what we see in Sjogren's syndrome is called focal lymphocytic cyradinitis. What this essentially means is that around the duct or around the blood vessel, so periductal or perivascular, you have lymphocytes infiltrating. So what is this focus? The focus consists of 50 lymphocytes adjacent to a normal lobule. Why normal lobule? Because if the lobule is injured or inflamed, you will either way get lymphocytic infiltration. So that is why, to make sure it is Sjogren's, the lobule should be normal. So adjacent to a normal lobule, you get 50 lymphocytes, that is one focus. And if you have a focus score more than 1 per 4 millimeter square, this is supportive of diagnosis of Sjogren's syndrome. So what are the other pathologies that is seen? I would like to show you in the next slides. So one other pathology that is commonly seen is this is called non-specific chronic sialadenitis. What you can see is there is lot of fibrosis. Now the brown area represents the fibrosis. So you can see that there is lot of atrophy and fibrosis here, and the lymphocytic focus is around the region of the fibrotic lobes. So this is not Sjogren's syndrome. Okay? The other condition which is diagnosed as Sjogren's but which is not, this is sclerosing chronic sialadenitis. What you have here is there is lot of fibrosis, there is less inflammation. You just have scattered lymphocytes, you don't have a focus. Okay? So these two, that is sclerosing chronic sialadenitis and non-specific chronic sialadenitis, these are not Sjogren's. What is Sjogren's is focal lymphocytic sialadenitis. Okay? Now to show you, so again this is another pictorial representation. You can see the normal acini and then you can see the duct here, and around the duct you can see the lymphocytes. And when you count, there should be at least 50 lymphocytes. Okay? Right. Now, so this is how the actual histopathology looks like. On the left you have a normal gland, and here you can see the duct here. So you can see the duct here, and around the duct you can see the lymphocytic infiltration. See, this is the duct, and around the duct you can see this lymphocytic infiltration. And what we need to see is these acini are normal. So this is the non-specific chronic sialadenitis. You can see that there is lymphocytic clustering, but it is less than 50. And it is around the atrophic lobules. You can see that the acini are not fully normal. In this sclerosing chronic sialadenitis, you can see this pink material here is actually a whole lot of fibrosis. The glands are less in number. The glands are fibrotic. The glands are less in number, and the inflammation is actually very less. Then this is the grading that is used. It is called the Chisholm-Mason grading of the lip biopsy. So 0 means absent, 1 means there is slight infiltration of lymphocytes, 2 is moderate infiltration but less than 1 focus. Means you have infiltration but which lymphocytes are less than 50. So to classify as Sjogren's, you need grade 3 or grade 4. Grade 3 is 1 focus, grade 4 is more than 1 focus. So first we need to be sure that there is focal lymphocytic sialadenitis is the predominant pathology. Then you go to count how many foci are there. And to know the severity of the disease, you should actually calculate the total number of foci in 4 mm square glandular area. Now, there is always this controversy whether you need to do an invasive procedure or not. So, why should you do a lip biopsy? Let us look at why we should do. One, as I have shown, it is a relatively safe procedure. It is minimally invasive. Sensitivity varies from 63.9 to 85.7%. Specificity is 61.2% to 100%. It has got definite diagnostic value. Like I said, when you suspect Sjogren's syndrome and antibody is negative. Second, you have isolated antibody positive, but patient has no subjective or objective features. Say you have a patient with renal tubular acidosis and you are suspecting Sjogren's syndrome. Antibody is positive. Objective and subjective SICA are not there. So that is one condition where you should go ahead and do the biopsy. Then, if your close differentials are sarcoidosis, IgG4 disease, this often happens because sarcoidosis and IgG4 disease can present with parotidomegaglandular swelling. So it also helps you to differentiate between these conditions. Amyloidosis, it is also done in case of hemochromatosis. So these are the different conditions where lip biopsy has diagnostic value. Now, whether lip biopsy has prognostic value. So it has been found that if the focus score is less than 3, negative predictive value for lymphoma is 98%. So you can essentially rule out lymphoma. We know that lymphoma is an important complication of Sjogren's syndrome, and if your focus score is less than 3, the chance of lymphoma is very rare. The other prognostic value is that focus score more than 1 has been associated with the main phenotype features of Sjogren's, high serological positivity, high ocular staining score. and unstimulated whole salivary flow rates. Now, other prognostic value, I would like to show two specific things. So, what happens is Sjogren's syndrome is a type of lymphoma. It's a slow-growing indolent lymphoma. You can also call it that. So, what you can see is in Sjogren's syndrome, where the risk of lymphoma is very high, you can actually see this is a germinal center. So, sometimes the pathologist may call and say, "Are you sure you have sent the lip biopsy? Because this looks like a gland." It would look like a gland when the lip biopsy is studded with germinal centers. So this can happen, and when you see a lot of germinal centers, you know that this patient has a higher risk of systemic complications as well as risk for lymphoma in some studies. The other condition that is seen, this is something called a lymphoepithelial lesion. What you are seeing here, this is the duct, and there is the lining of the duct. So the lining of the duct, there is proliferation and there is infiltration into the lining by the lymphocytes. So this is mainly seen in the parotid gland biopsy, not so much in the minor salivary gland biopsy. And if you see this, this is again an indicator for lymphoma. Okay. So what are the reasons for not doing a lip biopsy? Because it is an invasive procedure and there is not much utility in a case of clear Sjogren's with anti-SSA positive. And especially if the pathologist is only going to report it as positive or negative, when you already know that this patient is a diagnosed case of Sjogren's, it does not hold much value. So that is why I said we need to talk to the pathologist. And there is wide variability in reporting, as seen in these two papers. And if you look at the inter-observer values, you can see that the most important part is, like I said, focal lymphocytic salinitis. And you can see that the kappa values are only 0.46. Which is not very good. So, we need to have a discussion with pathologists before we start doing biopsies at each of your individual centers. Now, next we'll be talking about, do you have any questions? Ma'am, should I share any questions regarding the biopsy?
You can show your video and after that.
Okay. So then we'll talk about the salivary flow.
You want
So,
to finish showing your video?
So this video is available on YouTube and it has been made by Dr. Surat Arya. Here you can see that the cleaning draping is done. This local is being given. So if you are not using a calacion or a clamp, you have to constantly apply pressure with your thumb and index finger. So like he is doing in this video. And this is the most important part, please pay attention. So you just nick on top of the gland. Okay? When you nick, the gland will pop out. See the gland that is popping out. So this is actually a lobule. You can have, there may be some 3 or 4 glands within that lobule. See, that is how a gland looks like. So with this technique, the bleeding is very, very minimal. You just need to apply sustained pressure after the procedure for 1 minute. And then before the patient leaves the room, you again check whether there is any bleeding. That is all that needs to be done.
Are there any questions till this point? Anybody has any doubts or questions till this point? how do you transport this sample in
Formalin, 10% formalin.
10%?
There is always a chance that the minimal invasive procedure may not be good enough in some patients. So sometimes, so you can take a consent for that as well, that sometimes you may need to extend. Other than that, there is no precautions as such.
You've given very nice, useful tips, Dr. Sanjay. Any questions?
One question, ma'am.
Yes, please.
How to dissect the gland tissue?
So I will just, if you would like, I can play the video again. So you are just using the blade to dissect. So you give the local, okay, just over the area where you have identified the glands. The glands are very superficial. As you nick, you just continue nicking till you see the glands popping out. And you just dissect. There is a very thin fibrous tissue there. There is a thin layer, it's like a film. So when you nick it, it will also open up and you can see the glands just popping out. I wish we could have a live session. That would have been much better.
We can't do that. So, if we try to dissect the gland, we will be injuring the lobules, right? So, I don't think we should be dissecting the whatever pops out, the contents which pops out. Am I right?
You just need to remove that thin layer of tissue that is there. The gland pops out with the lobule, so you don't get a single gland, it just comes out like a lobule. If you are having individual small glands, you need to take at least 4. If you get a lobule, that which itself may consist of 4 or 5 glands, you just remove that lobule and send for histopathology.
Is there any time during which the sample should reach the pathologist?
No.
There is no such thing.
No.
Any other questions?
Ma'am, regarding the interpretation of the biopsy, absence of, presence of normal SNI is it essential, or can the patient have atrophied SNI?
Okay,
I
so
think that will depend on the duration of the disease and the severity.
right. That is a very good question. But essentially, you can have atrophy, fibrotic area, but there should be at least some area where the SNI is normal. You should have, so you can have coexistent non-specific chronic silentinitis. That is acceptable. You can have areas of atrophy, you can have areas of fibrosis, but you should have some areas where the SNI are normal, and you should have some area where you have this characteristic FLS. Without that, you can't make a diagnosis. The only exception to that, where you don't have FLS and you can still make a diagnosis, is in case of parotid gland biopsy, where you have lymphoepithelial lesion. So even if you don't have the focal lymphocytic silentinitis, the lymphoepithelial lesion which I showed last, that is so very characteristic that you can make the diagnosis even if you don't have FLS. For all other conditions, you need to have FLS. And FLS must be the predominant feature. This is because sometimes in elderly patients, you can get inflammation, you can get infiltration, so that we do not overdiagnose. Even 8 to 9% of normal population can have infiltration. So that is why that rule is very specific.
So the staining, only HNE is sufficient.
Yes.
We never need to do IF or anything in salivary gland biopsy.
Unless we are doing it for research purpose, where to see germinal center, they use CD21 stain. You can use CD20 to see the B cell infiltrates. You can use CD3 to see T cell. So the earlier stages of Sjogren's, there is T cell infiltration is predominant, and later on there is more and more of B cells. But unless it's a research center, routinely the pathologists don't do the staining.
If there are no more questions, we will.
What if in India, what you find is people are taking a lot of tobacco. They're chewing a lot of tobacco, and that is also leading to some sort of a microinflammation going on. So, has it been studied? What is the impact of biopsy on chronic tobacco chewer, those who are getting a little bit of submucous fibrosis, or any correlation with the age of the patient? Like this is in young, you find that this type of beautiful appearance will pop out, but as you go in elderly population, 60 plus,
Yes, so
people-
that is very important. So in elderly population, like I said, there is chance of getting infiltration. So you can see lot of non-specific chronic sialadenitis. That is point number one. Second is, they have found that the fibrosis actually does not correlate much with age. There is a recent paper which says that fibrosis, like Dr. Shankar Naidu had asked that interesting question. They found that because in long-standing Sjogren's, you can get fibrosis otherwise also. So it is more a part of the disease than age-related. That is what they have found. The other thing, tobacco can decrease the appearance of infiltration, and it also leads to more of NS, non-specific chronic sialadenitis. It makes interpretation difficult. But luckily, most of other patients are in our country are females and non-smokers. So, but there is an influence on tobacco on the scoring. It has been shown.
The tobacco chewing and the tobacco related issues are mainly in the submucous fibrosis and the buccal mucosa, not usually in the lower lip from where we are taking a biopsy. So I think that's one more reason why we don't discuss this matter at all of chewing tobacco or
in
pan.
Indian population, what you see is they not only chew tobacco, they keep the tobacco, and that is typically
In the
on the
lower
lower
lip.
lips.
But the submucous fibrosis, to the best of my knowledge, is in the buccal mucosa, not really in the lip area.
We see submucous fibrosis like completely kind of closed. But tongue is not able to follow. So one has to see that. But fortunately these two
Because
combinations.
in Western literature, this data is there that smoking can influence the
So
soul.
we consume tobacco a lot by chewing rather than smoking.
Yes, I understand. Yes. I do not think that has been studied.
And that
Maybe
has
yeah,
got a lot of
yeah.
contaminants as well.
Yes. I don't think, I think it's a very interesting thing.
Yeah,
to
I think
study.
that's a research question
Yes,
which we should
yes.
answer from our
Answer,
country.
Yes. Because the data that is there is on smoking, not on tobacco chewing.
Because in India, if you're looking at that, nicotine in the form of tobacco, chewing is more brilliant than smoking. It
Northern
blocks-
India can answer this
Yes,
question.
yes. I think it must be looked into. Thank you. Very good question. So shall we move on to the salivary flow? So these are the known values for flow rates for whole saliva. So what we are trying to estimate is the whole salivary. We are not going to measure individual, like there are techniques for doing that. Individually you can measure saliva from parotid gland, submandibular, sublingual. But what we are looking at is the whole saliva, and unstimulated or resting whole saliva, the normal rate is 0.3 to 0.4 milliliter per minute, and less than 0.1 ml per minute is considered as slow. Whereas for stimulated whole saliva, it is 1 to 2 ml per minute, less than 0.7 per ml per minute is considered as slow. So what I would be showing is how to do the unstimulated whole saliva. So what you need is very simple things. You need a 15 ml test tube with graduated markings. You need a 55 millimeter diameter funnel that will sit on top of this tube, and you need to assess the time. So you ask the patient to lean forward and passively, okay, and one more thing I have to mention is, all this is influenced by circadian rhythm. So you have to be consistent in the time. For example, early morning hours, the saliva production is less. It peaks towards afternoon. So when we are doing, we have to be consistent, and generally I think 9:30 to 11:30 would be a good time to do the procedure. Okay, so what are the instructions to be given to the patient? First, most importantly, the patient should be seated comfortably in a quiet room and with the head stooping forward, and patient should keep the eyes open. Now before the trial, the patient should refrain from food. Water is acceptable. 1 hour before the test, smoking and chewing gum are preferentially avoided the day before. Rinse mouth several times with water, then the patient is asked to relax for 5 minutes. Now during the trial, just at the start of the trial, you have to ask the patient to swallow the existing saliva that is there in the mouth. And most importantly, patient should move as little. Remember, this is the unstimulated salivary flow we are trying to measure, or the resting saliva. So the movement should be kept as minimum as possible. Open mouth slightly and allow saliva to drain passively over lower lip into the tube. And the most important thing is the patient has the habit of swallowing. So many of the times, patient cannot resist swallowing. That is a problem I found while doing this. So you have to instruct the patient not to swallow. At the end of the test, so you can do it either for 5 minutes or 15 minutes. So generally, people do the unstimulated for 5 minutes, then they proceed to do the stimulated. In our clinic, we just do the unstimulated. So at the end of this 5 minutes, you ask the patient to collect the remaining saliva and spit out, and you measure what is the saliva collected over the 5 minutes, and you express it as milliliter the instructions. And the timing generally 9:30 to 11:30, that is in the morning hours, 9 to 12.
How long should we stop antidepressants if the patient is on?
So there is no recommendation actually to stop because it is going to be difficult. So you can, so what they say is anticholinergics, if possible, you discontinue. But in many of our patients, it is not possible to discontinue antidepressants. So you do it along with them.
Dr. Smriti has a question.
Most of our patients did not take too many instructions. So I found 3 important instructions which they could take. Be relaxed before you do it. So get relaxed before they are well taken. More than that, then they mess up.
Nice tips, thank you. May I request all of you to please introduce yourselves before you ask the question, because I don't know many of you, so I'm sorry about that, but please do so. Any other questions? Yes.
I'm Dr. Sorman from Ma'am, do you find a lot of false positives then? Because you say that the most difficult thing you find is that people keep swallowing. So how do you differentiate then? Because or is there someone absolutely observing for 5 minutes if they've swallowed or not?
See,
Do you do best of 3?
yeah, you ask them to do repeatedly. That is all that you can do. And generally, people should have, so if you have borderline low value, so they have also found that this 0.1 ml is a very stringent cutoff. So if you have it on the lower side, that is also enough to support your diagnosis, meaning a clinical diagnosis. This is for the criteria. So it is very difficult, and the swallowing thing happens. I don't know, you can't help it. Even patients who are experienced, it tend to happen. I ask my staff to see, and I check with the patient if they would like to try again.
Okay, move on to the next section now.
Okay, so the next one is on the tear film. So there are 3 layers. So first you have the mucin component. This is produced by the goblet cells. Second, there is an aqueous component that is produced by the lacrimal gland. And third is the lipid layer produced by the meibomian glands. So which layer is affected in Sjogren's syndrome? Aqueous. So aqueous deficiency is what is there in Sjogren's syndrome, followed by what is otherwise commonly seen. Other than this, second most common, meibomian. So meibomian gland dysfunction is seen in 30 to 40%. Okay. So we should have this picture in mind. So how can we assess the aqueous layer? That is by the Schirmer test. Okay. So this measures the stimulated reflex tear flow, because you have a Schirmer test with anesthesia and without anesthesia. So we will be doing the Schirmer's test without anesthesia because it has been found to be good enough. So this is, we are measuring the stimulated reflex tear flow. So first we need to explain the process to the patient. We have to fold the Schirmer paper strip. So this is a 5 into 35. Have you all seen the Schirmer strip? All of you have seen the Schirmer strip? If not, I can circulate. So the Schirmer strip should be folded at the notch. It is a 5 into 35 millimeter strip, and you open and remove the strip from the opposite end, so that you are not touching the area which you have bent. So when the strip is still inside, that is when you bend it, then you open it from the opposite end and hook the folded end over the temporal 1/3 over the lower lid margin. Okay, and in this, unlike shown in the figure, the eyes must be gently closed. And score is the length of wetting from the notch after a period of 5 minutes. So the problem with all this tests, whether unstimulated cerebral or Schirmer's, you can see the sensitivity specificity is not very great. And less than 5 millimeter in 5 minutes is suggestive of dryness.
Can you circulate the paper strip?
can take and stimulate it.
Are you going to cover this?
So I am not going to talk about it. The process is the same. What you do is the same instructions. Only thing is you use either an inert gum or a candy, non-sugar candy you can use, and the patient is asked to repeatedly chew. So there are instructions on how frequently you must be chewing. You chew, spit. So that is the process. Otherwise, the remainder of the process remains the same. So first you will do the unstimulated, followed by the stimulated. So I just show the video. So like I said, that is the area where you have the notch, if all of you have seen it, and you open it from the opposite end. So don't touch the end which will go into the patient's eye. And so this goes to the temporal third of the lower lid margin. And you wait for 5 minutes. You do the same process in both the eyes simultaneously. I did not show that in the interest of time.
The room has to be any particular specificities about the room, dark, well lit.
Yeah, it should be a light lit room. Not brightly lit because we do not want too much of stimulus.
And the room temperature, ambient. What about in northern or when it is very cold or very warm in southern?
There are no specific instructions as related to this.
So any instruction not to use the screen for some kind of
No.
computers, laptops
You should not, see, during this process it should not be stimulated.
before the
Before that is not an issue. Because you are going to do it in the clinic, the patient you are seeing as you are examining and you are writing your notes, that is when you do that is how I generally do. So once I finish my examination, as I am writing the notes, that is when I do, and patient is seated in front of me. So the other ocular staining I will just briefly mention, this is done by an ophthalmologist. So just to have an idea of how things happen. So what you do in ocular staining is conjunctival and corneal epithelial cell damage happens in children's. So you use dyes that stain areas of devitalized tissue. Previously, rose Bengal staining was used and this stains the cornea and conjunctiva. However, because it's very painful in patients with Sjogren's, rose Bengal has been abandoned and now what we are doing is the fluorescent and dissemin green has taken its place. The fluorescent stain is used for two purposes. One is it stains the cornea, and second, you can also measure the breakup time by using the fluorescent stain. And second, glycerin green is to stain the conjunctiva. So it is done in this order. First you will do Schirmer's, then you will insert the fluorescent stain, measure the breakup time, then you look at the cornea staining, then you insert glycerin green, and then you look at the conjunctival staining. So this is the process in which ophthalmologist operates. So first talking about tear breakup time, like I said, these two processes request slit lamp examination can be done only by ophthalmologist. So basically, I just want to show what happens. So you insert fluorescent either with a pipette or a wetted strip. So you take a Schirmer strip that is wetted and you insert that into the eye. You ask the patient to blink thrice. So this is to ensure adequate mixing of dye with tears. And tear breakup time is the time between the last blink and appearance of first dry spot in the tear film. So again, like I said, all these tests have poor sensitivity and specificity. So just to show a diagram here, so this is after the patient, you have inserted the A. A figure is, you have put in fluorescent. Patient has, after the 3 blinks, okay? Then you look at the eye, and B is when the first dry spot has appeared. If you see, this is the first dry spot. So the time from node, the last blink to the appearance of first dry spot. So that is what is the tear breakup time. So if a tear breakup time is less than 10 seconds, it's abnormal, and this is suggestive of meibomian gland dysfunction. That is the outermost layer. And you can see what happens. So if you don't blink, see, look at the eye. So this is the first dry spot. But if you wait long enough, so you can see these dry spots. Okay. And then about ocular staining. So this color thing is intentional, it looks terrible, but because we need to remember that conjunctiva is stained with receiving green and cornea is with fluorescent. So that we remember, that is why that color has been used. So there are two ocular staining systems that is used. So one is called the Van Distelwald scoring system, the other one is the ocular staining score. Now both of them, what is common is the nasal part of the conjunctiva has a score of 0 to 3, the temporal part of the conjunctiva has a score of 0 to 3, the cornea has a score of 0 to 3. So the total score is 9 for this Van Distelwald scoring, and if you have a score of more than 4, that is indicative of Sjogren's. Now what is add-on in ocular staining score is the cornea gets extra 3 points, one each for pupillary staining, filaments and confluence staining. So that is how the score for ocular staining score is out of 12, and if the score is more than 5 in any eye, it is suggestive of Sjogren's. So this I will not be able to demonstrate, so we don't have a video for this. Thank you.
Thank you, Dr. Sandhya. I think we've taken most of the questions in between the subsections. So if there are still any questions, maybe Dr. Sandhya can take it post the entire session in the afternoon. Thank you so much, Dr. Sandhya. Very well done. Next we have Dr. Funny, who's going to talk to us about muscle biopsy procedure. It's actually a bedside procedure again, and it's not really in anybody's domain, plastic surgery, neurologist or rheumatologist. So it's a very easy to do procedure which we can do on the bedside, and it's something which I feel that can equip us in making the diagnosis of myositis a little bit easier. More so because as the patients are given treatment, they experience steroids, immunosuppressive therapy. Sometimes the pathologists feel that the degree of infiltration of the inflammatory cells changes as we treat the patient for longer time before we do the biopsy. So if we can do it at bedside and we can all learn to do it in a uniform manner, that will be really great. So Dr. Fani.
Yes. And I think when we talk about muscle biopsy, I think I make it very simple for a clinician, because one thing about getting the tissue, and the second most important part is processing the tissue. So which I will be covering in this session, covering the both. But I thought what will be more relevant to the clinicians, to this crowd, I felt those are being included in the talk. So my overview of the talk will be talking about the indications of the muscle biopsy and the procedures regarding the different methods to sample the muscle and how we process the sample, complications out of this procedure, and the most important is the muscle biopsy interpretation, and the last about the troubleshoots which are more common. And as you know that muscle biopsy is very important tool for evaluation of neuromuscular diseases presenting with acute or progressive muscle weakness. And we know alongside of clinical examination, because what are the diagnostics we do, they all should be alongside of the clinical examination, which helps us to provide diagnostic evidence and narrowing the differential diagnosis. And any planning of any procedure should be, because these are all diagnostic procedures, there should be constant dialogue between the procedure done person and also the lab. So there should be an optimal planning for any biopsy. So coming to the indications of a muscle biopsy, when there is an evidence of muscle disease in form of weakness, which is most probably the proximal, which is more common, and having myalgia, cramps, fatigue, and elevated CPK, and myopathic ENRG, and systemic disorders with muscle involvement like sarcoidosis, vasculitis, and in cases like hereditary muscle disease in family members, and there are variants of undetermined significance for the genetic testing in muscle disturbance where you need a muscle biopsy to further study. And this is a working classification of muscular disease, because whenever we do muscle biopsy, I think as I said, it involves neurogenic disorders, neuromuscular disorders, and the primary myopathic changes. And further today we are more interested in this primary myopathic changes, which most us are more interested in the inflammatory diseases, then the dystrophies, the congenital, which comes more to neurologist domain, and the metabolic, which may give you some cases how to differentiate them with inflammatory. And the last and least should be endocrine related and the drug related, which is most important. And this is a one list, the exhaustive list, but I just made it simple with labeling them with a diamond. So these are myopathies where there is no requirement of muscle biopsy. So this I think because we deal with inflammatory myositis, when you come to most of the dystrophies like myotonic dystrophy, oculopharyngeal muscular dystrophy, periodic paralysis, OCMD, that's oculopharyngeal muscular dystrophy, facioscapulohumeral dystrophy, mitochondrial disorder, because they are more into the genetic side. So people now recommend to do genetics first, then go for a muscle biopsy. And which muscle to biopsy. So this is very important when you select which muscle to biopsy. So when you see a chronic disease, which in the inflammatory group, so moderate involvement is nothing but having a muscle power of strength 3 to 4, and not less than that and not more than that, because it doesn't give you the yield. So I think now people, based on the clinical examination, people go with doing a lower limb muscle biopsy, which is vastus lateralis. And now people do imaging, because in some cases, if you still have a doubt of muscle involvement, and an imaging may help you to guide the biopsy. And when it is an acute disease, the severely involved, because one thing comes to everyone mind is immune-mediated necrotising myositis, where you should biopsy a severely involved muscle. And biopsy should be taken from the muscle belly, not from the myotendinous junctions. And in the picture depicted here, you can see that the proximals which can be done are the quadriceps, which is the most common from the vastus lateralis belly, and the biceps and the deltoid. And the distal muscles are tibialis anterior and gastrocnemius. And the avoid section is, I think, I want people to focus on, that I told before, the severely affected muscle, minimally affected muscle with a power of more than 4, they should be avoided. And EMG site, so that is very important. Whenever people come with an EMG report, definitely you should do biopsy on the opposite side, not from the EMG side. Any injections, trauma, and tendon insertions, which I said it should be done from muscle belly, done from the myotendinous junctions. And coming to the procedures, because we have over years, I think procedures has been started. With the surprise when I read about this procedure, because it is started by Duchenne, which is a needle biopsy, which is initial to start. But I think centers do based upon their experience and preference. So coming to the types of biopsy, we have open muscle biopsy and the needle muscle biopsy, which is called semi-open biopsy, where you have Bergstrom and the modified Bergstrom and the Comcoat, which some centers are doing at present, and the fine needle biopsy, which is a microbiopsy, just like the kidney biopsy guns which are used for this procedure. And this is one slide which I made to say what are the differences between different biopsy procedures, because coming from the first 3 part of it is about the procedure and about the tissue obtained and the post procedure complication. When you go with needle biopsy, which is Bergstrom, so the incisions are very less than 5 mm, and the concotum biopsy, it is a mistake there, it is less than 1 centimeter. And coming to microbiopsy, as I said, it's a fine needle biopsy, there is no incision not required. When you talk about muscle open biopsy, the incision required is 3 to 4 centimeter. And local anesthesia is required with all the procedures. And general anesthesia for an open biopsy if it is a child. So the suturing, when you come to suturing, it is not required for needle biopsy, and concordum 1 to 2 sutures may be required. And microbiopsy, which is fine needle biopsy, is not required. And for open biopsy, we require sutures of 4 to 5. When you come to muscle sampling, because the needle biopsies, we have a limited muscle groups to do, and microbiopsy limited muscle group. But open biopsy has an advantage to get all, whatever the place, I think you can go and get a good muscle tissue. And concordum also is used in most muscle biopsy. When you come to the tissue obtained from the Bergstrom, which is a needle biopsy, it is 30 to 75 milligram per pass, but when you go to concordum, it is 20 to 290 milligram. And fine needle biopsies are with a very lesser tissue, so it is only 10 to 20 milligram. And the open biopsy definitely is an advantage, because you are directly seeing the muscle belly and you are taking the sample. It is almost to 1 gram. When you come into the pain, as I said, the invasive thing definitely has more pain. But hemostasis is well maintained in open biopsy, because you are seeing directly the vessel and you can stop any bleeding vessel on the table itself. And the scarring will be much more in open biopsy than the needle, concordum, and microbiopsy. When you come to the success rate with the different studies, they all go around above 90. And repeat sampling is definitely available with other biopsies, but not with an open biopsy, which taking a consent is not so easy for an open biopsy to do in a research setting. And equipment needed, either for a percutaneous muscle biopsy or for the open muscle biopsy, more or less the same. So the concordum, which is named after wheel Blakislee, which is the compound which has either 4 mm or 6 mm biting tip, and or a buxom needle, and we need syringes, scalpel size of 11, and sterile gauze, drapes, and chlorhexidine, and 5 to 10 ml of 2% lidocaine to anesthetize the site, and steady strips and stretchable bandages once you suture and close it. And this is a buxom needle, but it is of not much about now, so I will just say this is not mostly used for many. So it has outer proca and the inner cannula and then clearing rod. And I think there is a modification to this procedure by using suction to the needle, so where you get more muzzle. But these procedures are mostly not, but these are of historic importance to start with. And this is a concrete muscle biopsy which people do in some centers in our country. So it is just like looking like a curved forceps, and it has a biting tip which is of two sizes, 4 mm and 6 mm. The procedure will be anesthetizing the site, which I will be doing with a video on open biopsy, which our center regularly do. And again sterilizing the site and keeping it sterile and going perpendicular to the muzzle. And definitely once you should enter the site in a vertical position with the closed end, and once you enter and you feel the fascia, then you should open it, and where it has a biting tip, then to come out with the tissue. And people do it is with 2 to 3 passes, so that they can get a good amount of muscle tissue. And this is a microbiopsy just for interest. So this is just like a BART guns which you use for kidney biopsies. People use this, but the available tissue which can be extracted will be around 10 to 20 milligram. But people, this most to a research site, people use it. And coming to this open biopsy which our center do, so these are instruments required other than the lignocaine and the betadine, whatever, to prepare the site and to anesthetize the site. The most important is a scalpel blade of 11 size, and you need a curved forceps, an artery forceps, and a skin retractor to expose the muscle. And coming to the procedure, I think I will just. It's only to say the first part is identification of the site, which should be about 3 to 4 centimeters above patella. On the lateral aspect, I think first thing should expose the leg from where you are doing the biopsy, from the groin to the leg, and you should identify the site around 4 centimeters from the patella on the lateral aspect of the femur. Once you identify the site, so you should anesthetize the site with 2% lignocaine of 5 to 10 ml. That infiltration of this biopsy site. And once you infiltrate the skin and subcutaneous tissue, you should not infiltrate into the muscle, because it all will cause needle artifacts when you interpret the muscle tissue. That is more important. So the skin and subcutaneous tissue is infiltrated. Then an incision of 3 to 4 centimeters with surgical blade, longitudinal to the direction of muscle fibers, should be given. An incision of 3 to 4 centimeters should be given. And hemostasis should be maintained throughout the procedure. And with curved forceps, separate skin from the underlying subcutaneous tissue. Till the shiny fascia, which is covering quadriceps, is well visualized. So you'll be clearing the skin, subcutaneous tissue till you see the fascia. And the quadriceps has an unique thing, because most of the muscles are not covered with fascia, but quadriceps is a muscle which is covered with a thick fascia. So the fascia division is very important in getting a biopsy from quadriceps. And use a skin retractor to visualize the fascia and give a Iracon fascia which is longitudinal in line with the muscle. After the nick on the muzzle, biopsy muzzle will stand out by a vent. So I think so that you should hold with an forceps and separate muscle fibers of 2 centimeters from muscle belly and cut transversely on 2 sides of the muscle belly. And ensure adequacy of biopsy size, which is adequate is 2 to 2.5 centimeter. Is the adequacy of the tissue, and it should be in a vertical orientation, and you should send to the lab in saline soaked gauze. And what are the complications of the procedure? Potential complications are with allergic reactions to local anesthesia, infection, hematoma formation, localized numbness. And this one retrospective study, which included more than 13,500 needle biopsies by Tarno-Polsky et al. If you see the complications, there are, I think, less than 10 members out of these 13,500 biopsies with an arterial bleed, ecchymosis, local skin reaction, localized numbness, and pain lasting more than 3 days. And complications are rare with open method, but include infection, delayed hematoma formation, muscle herniation through facial defect, and wound lesions. So that is the reason whenever after the muscle biopsy, if you do by open method, you should ask them for a rest for 30 minutes and no strenuous activity for 72 hours. And you should also look for the site to remove the sutures and after 1 week of time. And how to, because once you got the biopsy, and the next step is to how to handle this muscle biopsy specimen. The first decision is in the processing, and the second decision is about how to evaluate this muscle. So you know the clinical profile of the patient. So then you should plan the tissue allocation based upon your clinical diagnosis. As I said before, it should be transferred to the lab immediately in saline soaked gauze, but not floating in saline, because floating in saline will imbibe more fluid into the muscle, which can have artifacts when you interpret the muscle. And ideally is immediate time, or till 2 to 3 hours, because when you send it to a lab very far, I think it is allowed for 2 to 3 hours, and you should send on dry ice, not to merge in the ice, but it should on the top of the ice. And if you see on this picture down, the most important part is played with the frozen muscle biopsy sample, which the tissue allocated is 80 to 90%. The most three in any lab studied nowadays are the histochemistry, immunohistochemistry, and the immunofluorescence. And when you want the other studies to be done, mostly the western blot, southern blot, muscle tissue molecular studies, the more to the muscular dystrophies than to an inflammatory myositis, and the mitochondrial respiratory chain to the mitochondrial myopathies. And paraffin block, I think the people allocate very less tissue, because the most of the tissue people make it as frozen and use it for this study. And when you have to study about the ultrastructural studies, like studying about the mitochondria, sarcoplasmic reticulum, then people use electron microscopy, where it should be immediately glutaraldehyde fixation in 3% of photos. And this one table to show, I just want you to highlight with the different sections what is the use. So when you come to the frozen section, people can study about the muscle fiber morphology, enzyme histochemistry, and this is the most diagnostic information with the light microscopy. The ideal amount of tissue should be 1 centimeter cube. As I said, it should be wrapped in light moist gauze and shipped to processing laboratory. And coming to the electron microscope, which I said for the ultrastructural analysis inside the muscle fiber, and the section should be 1 to 2 mm thick section, and it should be the 4% glutaraldehyde. And biochemical testing mostly with the lipid, fat storage diseases, mitochondrial diseases, where it should be, again, the frozen sample can be used. And as I said, the first step, which is more important in muscle biopsy, is taking a frozen section. The second step is evaluation of muscle biopsy depending on the diagnostic need of the case. So what a muscle biopsy lab, which our center have, so it is an essential, should be a liquid nitrogen supply, deep freezer, a minus 70 degree, when you want to store the sample, and the cryostat, and a pH meter in the balance, and fridge with freezer compartment, and an incubator or water bag 37 degree. And non-essential for most of labs when they are not into the research are dissecting microscope, ultra microtome, electron microscope, and the imaging analysis. And this is one picture to show. So on the top picture, I think this is a isopentan, which should be cooled in liquid nitrogen. This is a tank of liquid nitrogen, the cryostat. This is a superior way of cryostat, where you can see this compressor setting. So we should process everything at 20 to 25 degrees. And this is the cogs on the cryostat, where you place and you take sections out of it. And this is one video showing the processing of muscle biopsy. So as I said, the first step is transfer muscle biopsy on saline soaked gauze to cryolab. And the second step is place the biopsy tissue on silver foil in vertical orientation. And this step is showing removing the fascia around the muscle tissue. Once you clear the fascia, cut the muscle tissue in vertical direction. And transfer the muscle piece to a folded silver foil, which is shown here. And take a glass tube anchored with thread and fill it with isopentan. Mostly the 2/3 of the tube should be filled with isopentan, and it should be kept in the liquid nitrogen tank for 1 to 2 minutes. For having the freezing of isopentan to minus 160 degrees centigrade. And this is called the snap freezing, and keep the muscle tissue for 30 seconds in cooled isopentan glass tube. And take the silver foil to the muscle tissue which is frozen out of the glass tube. Take the frozen muscle tissue within 4 steps and apply an OCT medium, which is an optimal cutting temperature medium, on the cork and keep it in a vertical direction. And place the frozen tissue on the cork to the cryostat. Take transfer slices, which is around 10 micrometer, directly onto the slides. And this is directly to take on the strain and to carry with further staining, which I will be dealing in the next slides. Yeah. So out of this, an important step in specimen processing is use of isopentan. And principle is to snap freeze the muscle in isopentan cooled by liquid nitrogen. And this snap freezing allows the tissue to be cut for diagnostic investigation and prevents the damage caused by formalin fixation or ice crystal formation. And the OCD buffer, which I showed, it prevents thawing and the refreezing of the biopsy. And the second step is how you process after getting these slides. First step is the histochemistry, which is an art deployed to identify the nature of the chemical components within the tissue by means of visually observed chemical reactions. It has two things, because whenever you do, it is a non-enzyme base, that is hematoxylin and eosin, and the second is enzyme base. So these are the three, so because these are the exams which should be performed on muscle biopsy, which I highlighted is the most commonly done. That is HND stain and the enzyme histochemical stain, and then next is the immunohistochemistry, which is done on a lab basis when you have a doubt in the procedures. And other immunofluorescence, electron microscopy, muscle tissue molecular studies, these are done in research labs. And these are slides you make. The first 2-3 are with HND stain, and the next are about the enzyme studies. And before going to the processing, I just want you to understand how a normal adult skeletal muscle look on an HND stain. You are seeing a transverse cut of muscle tissue, which you are seeing in packed polygonal structures, which are the muscle fiber. It is surrounded by a very thin sarcolemmal membrane, and it is around the muscle fiber you have a thin connective tissue, which is endomysium. And you are seeing this, and all these muscle fibers are packed, and it is surrounded by perimysium, which you are seeing as a septa here. And these all the group of vesicles are surrounded by epimysium. So we are very much interested in seeing the muscle fiber, which is surrounded by endomysium, which is one of interest to see an endomysial pathologist, and also the perimysium, which is a septa leg, where you say perimysial pathology. And before going to it, you should understand a basic concept of motor neuron. What is a motor neuron? It consists of somatic motor neuron, which comes from the ventral horn of spinal cord. And we know that we have two types of muscle fibers, type 1 and type 2. And if you see the two colors coded, so the neurons will have a tropism, and it supplies only one type of muscle fiber. So which are the green with the type 1 and the purple with the type 2 in a depiction in this figure. And you are seeing this HND section down, and this is an ATPase chain where you have a fiber typing, so which I will be going in the next slide. So we have different chains to be used. One is about the morphology with HND, modified glomeruli trichrome. The second is the fiber type enzyme to identify which is the fiber, type 1 and type 2, because we have the most common enzyme which is used ATPase, and most of the labs use ATPase of pH of 9.4 and 4.6 to identify type 1 and type 2 fibers. And we have oxidative enzymes. These are nothing but, if you remember our biochemistry of mitochondrial respiratory chain. So these are about the complex 1, 2 and 4, which have NADH, SDH and cytochrome oxidase, which are more with the mitochondrial pathology. And acid phosphate, alkaline phosphate more with the lysosomal and vacuous and macrophage pathology. And the storage material we use fats for glycogen and oil red O or Sudan black for lipids. So this is one picture. This is the top picture is showing the transfer section, the longitudinal section. But most of the labs take the transfer section. And this is one table to show what the type 1 and type 2 fibers, because understanding this makes you to understand which chains will help you to identify which fiber. And as we know, the type 1 muscle fibers is slow twitch, rate, and they have high mitochondria, glycogen low, and they are more with an oxidative phosphorylation. So all the mitochondrial pathology, the chains used are with concentrating the type 1 muscle fiber. When it comes to the type 2, which is a fast switch, white, and they have low mitochondria, and then high glycogen, and they are more with an metabolism, phenomenon like glycolysis. So in a normal skeletal muscle, the ratio of type 1 and type 2 fibers are 1:2. In the distinction between fiber types is usual to find fiber type predominance, fiber type disproportion, and selective fiber type atrophy, and fiber type grouping. I think the third one which we are interested, because whenever your lab gives type 2 atrophy on steroids, so you should understand the selective fiber type atrophy and how to identify them. And these are the pictorial depiction of different chains. On the top is an ATPase chain of pH 9.4, where the type 1 fiber is pale and type 2 is dark, and ATPase pH of 4.6 is the second part, where the type 1 will be dark and type 2 is pale. And if you go with, as I said, the mitochondria are high in type 1 fibers, you can see the depiction, which is, I made it as a plus symbol here. What are being depicted is an SGS chain, COX and NADH. The type 1 will be more darker than the type 2 fibers. And this is a PAS and oil red O. And the second part of it is, I think the enzyme experiment is done by most of the labs. But when it comes to the ISC, it is done by only with very few labs. So based upon your diagnostic dilemmas, we have a lot of markers for disturbance, which I will be going through. I will be going through of our interest, because whenever you have a doubt of inflammatory myositis, some labs do, our lab do, MSC 1 staining, CD68, CD20, CD8, and also the membrane attack complex deposit on capillary endothelium. Then how to interpret, this is the last part of my talk. So when you get this muscle biopsy, so I think when a pathologist gives the report, they first differentiate whether it's a myopathic biopsy or a neurogenic biopsy. How to identify myopathic biopsy? I made it simple. So having atrophy, hypertrophy of muscle fibers, scattered distribution, and myonecrosis and regeneration. Whenever you see, I think the myopathic process should be kept in mind, and then internal nuclei, split fibers, and endomysial fibrosis. When you come to neurogenic, you see an angulated atrophic fibers, pycnotic nuclear clusters, target fibers when it is an acute denervation, and fiber type grouping in reinnervation. So this is the picture to say neurogenic, you don't see no fibrosis, you see this atrophy, the smaller fibers here, and the nuclear clumps here, and this is the fiber type grouping. As I said, they have a tropism for each type of fiber. When type 1 fibers go away, the sprouts of fiber of now which is supplying the type 2. So they grow, so they hypertrophy. So this is called the type grouping, which is seen in chronic denervation. And this is one, I thought I should spend some time. So how a pathologist divide based on the histology section, stayed with HND and modified glomeruli trichrome, and how they classify this myopathy. And they classify into six types, saying that active myopathic damage and inflammation, and where you see necrotic muscle fibers, regenerative myofibers with inflammatory cells in endomysial and periphyseal. This is the part which we are interested in idiopathic inflammatory myositis. And there are some muscle dystrophies which can mimic as inflammatory myositis, that should be kept in mind. And the second is active myopathic damage without inflammation. This is mostly seen with IMNM, toxic and muscle dystrophies. And chronic myopathic changes, where you see most with the dystrophies having fat replacement, endomysial fibrosis, and the inclusions and vacuums, and with biopsies mainly with atrophic changes, which we are interested in. As I said in the previous slide, the neurogenic atrophy, endocrine disorder, prior steroid use. In the normal biopsy, it will be because of a patch involvement in the muscle involvement in diseases, that you can get an unaffected muscle tissue or in a metabolic myopathy. If you see this list of diseases, there is a lot of overlap between muscular dystrophy and inflammatory myositis. So definitely you should go with the clinical particles. And these are some pictures to show how acute myopathic features of inflammation look. This is one showing the perivascular infiltration. The second is about the myophagocytosis, and the third is perivascular atrophy, which you can see, which is very typical of a dermatomyositis. The down picture is showing chronic myopathic change. You can see the total FA structure with a lot of endomycin and perimycal fibrosis. And you are seeing a fiber discordance. Some are hypertrophied, some are small. And you are seeing this infiltration with macrophage, which is myophagocytes. This is a split fibers, which is mostly seen in muscular dystrophies. And this is one report which I thought as a sample report, which our lab reports. If you see the first part, there's an interesting thing which I seen in my myositis clinic last week. So if you see how they report has muscle biopsy initially with the architecture, how the architecture is, and the variation in the fiber side, and in this case showed atrophic degenerating regenerative fibers, fiber splitting, and hypertrophy is significant. As I said before in my classification, the splitting fibers, hypertrophy is more significant muscular dystrophy. And there is only single focus of perivascular lymphocytic infiltrate. So they opened initially in 2016 as muscular dystrophy. And if you see the enzyme stains are more or less normal. And which we reviewed again in recent year, because patient has evolved to develop a scleroderma symptoms, and which we thought it may be an overlap myositis. When we reviewed it, the inflammation biopsy is significant of the same slide, seen in perivascular and endomysial region. And when we did an MSC1, which is an immunohistochemistry, there is a diffuse overexpression along sarcolemma. Then we came to opinion it is an inflammatory myositis. So saying that all the diseases may overlap in muscle biopsy features, which should be taken in a clinical context. So the troubleshoots mostly can be pre-procedural, mostly the traumatized muscle of injection or insertion of EMG needed, procedural, cardiac artifacts, and the contraction band. Post-procedural processing, as I said, should not be sent in excessive saline. And processing, when I said if you don't froze the sample very soon, there will be ice crystals, which may pose difficulty for a pathologist to report. And the staining, whenever you have an excess or little stain, it will not be suitable for interpretation. As I said before in my talk, the myotendinous junction, you should not take from myotendinous junction, where you can see these small atrophic fibers, which can be normal, so that is you should take from the belly. And this is an interdigital structure of myotendinous junction. And you can also see this is a muscle spindle on a magnified view. This we can take it as an inflammatory infiltrate, but it is a normal muscle spindle. And one more, if you send a dried sample, you can see how the muscle fibers separating from the sarcolemmal membrane. And if you send an excessive saline, you can see this edema, where you can't interpret the muscle biopsy. The third troubleshoot is about ice crystal artifact. If you don't freeze the sample very soon, you can see this pores-like structure in the muscle fiber, and which will displace and which is not suitable. So in this, people do again thawing and refreezing the specimen. So it also helps in reinterpreting the sample. And to conclude, muscle biopsy is useful for diagnosis and narrowing differential diagnosis muscle disease spectrum. And muscle biopsy should be from moderately affected muscle in chronic myopathy, severely affected muscle in acute myopathy. And vascular is a commonly sampled muscle because of the good normative histological data. And minimally invasive biopsy techniques like needle and microbiopsy. So they have good safety profile, but only with the limitation of the adequate sample. And frozen biopsies are important in processing, apart from the contrast to the formalin fixation in most of the tissue processing pathology. And histochemical staining, both non-enzyme and enzyme based, are routinely done by myopathologists and rest on case-to-case basis. And pattern muscle disease should be broadly classified into neurogenic and myopathic process. As I said with my one case, saying that there will be a lot of overlap among various myopathies, they should be correlated with clinical examination. And artifacts in muscle biopsy from pre-procedure to processing should be considered in proper interpretation. And as I said before, to start my talk, muscle biopsy interpretation is possible in context of clinical, neurophysiological, and serum enzymes data. So these are my references, the slide, and I likely to acknowledge my pathology colleagues and my own rheumatology colleagues and Mr. Yognath, which is a research coordinator, and Dr. ma'am in editing this video for me. Thank you.
question on the procedure per se, not so much on the interpretation, I guess, because we're supposed to focus here on the procedure. So there is one more technique which we use at St. John's, which is concotome muscle biopsy, and that's much less invasive and less painful, and there is a video of that on the IRA YouTube channel. Any of you are interested can take a look at it. One question I have for you, Dr. Pani, your talk was very exhaustive and very nice. I remember that we used to stretch the muscle, we used to tie sutures at both the ends and tie it to a wooden piece and stretch it and send it to the lab. That's no longer done, is it?
I think now people stop doing it, madam, because people say they can have a contraction artifact when you tie it on a clamp or on a wooden piece, which we did in PJ when I am a resident there. But now people, if the lab is very nearby, people just want to transfer the tissue immediately to the lab and froze the tissue.
And also one more thing we used to do was we used to put a suture or something underneath the muscle belly, then pull it out, and then cut on two ends. So it used to be much less traumatic, is what I remember. I don't know if it's still being used like that.
But stage sutures are being applied, madam. But this depends upon their experience in doing that issue, because which I posted a video was from a pathology department. So they don't find any difference by keeping a sutures or without sutures.
How about a center which is not doing a frozen section and a microtome which you have got, and then you can immediately stain it and proceed with that. Suppose I want to send it to a referral center, muscle biopsy. Precisely as a postgraduate student, we used to do the muscle biopsy in the same way. We used to pull the belly up, and after both ends are cut, we used to tie the wood stick and send to the lab. And that time it was formally not normal line, because we were not doing history on that, we were not doing value studies on that. So that's one thing, but that is for a very outside lab. It's not available everywhere.
But normally, as I said, I think it should be immediate ideal. But if you want to transfer to another center, people say to send on a dry ice, maintaining temperature of -20 to -30 degrees, but it should be reaching the lab within 2 to 3 hours, which ideally should be a setting to close the sample.
So we send our samples to Nimhans, which is about 7 kilometers from my hospital, and 7 kilometers takes 2 hours sometimes. So we do, in the refrigerator you can keep those ice packs frozen, and you can just tie it to that, put the box on this thing, and in an ice pack you can send it. But you're rightly pointing out that not everybody will have these kind of facilities. It means they have it like right next door.
Yeah, next door.
So I think you can send it in an ice pack.
Ice pack, yes.
But they have 2-3 hours.
Yeah.
2-3 hours.
But ideally it's 2 to 3 hours.
That's the max.
Yeah, that's the max.
It's only possible in bigger cities, smaller cities don't have cryo. I don't think there's a cryo lab in India.
Yeah, so they will probably be just doing formalin fix H&E.
But nowadays people say formal fixation should be avoided.
Yes.
The ideal should be avoid formal fixation. Because it will damage the whole tissue where you can't do any enzyme studies on it. Because it will not be, because all enzymes are labeled. So to keep it frozen will help you to study all those enzymes.
No, the question, Dr. Funny, here is that if you are anyway not going to do enzyme studies or anything like that, then how should you transport it? And then how much is the need for being quick?
Which I said as before, because normally when you want to, it should ideally is the same time, but when you have the 2 to 3 hours is the ideal time, which most of the studies say, and people have seen transporting it overnight also will not help you, because people say either to freeze it in -80 degrees, because when you have this facility not available, I don't expect -80 degrees centigrade freeze will be available with many places to store it overnight before you send it.
So you had something to say?
Yeah, that's what I'm saying. Because most of the time what we find is we have to differentiate between a polymonocytase and a monocytase. But that's in a clinical scenario. And will not that, in that situation, a formalin stain, because we want to look at a very infiltrate vis-a-vis a muscle infiltrate. So that is that not possible by a simple formalin stain? Because most of the labs they do it like that. Now that we have got labs which have got facility of doing everything, but clinically these are situations where we try to see. Otherwise, the neurologists, when they come across a very complicated sort of a muscle disorder, they are not able to precisely pin down. But in rheumatological practice, your concern is essentially acute myositis or dermatomyositis. And you want to have a differentiation between these two. So will that help?
I think formalin, I think people talk about this paraffin embedded thing to fix again formalin. Definitely, I think it should help in knowing about on an HND, on a light microscopy, to say the difference about the endomysial involvement or the perimysial involvement. It should do so.
So most of the time we are interested in that area.
Yes.
So I think the pathologists are not very happy unless they are able to run the enzymes. Any pathologist with a typical kind of setup. So I think the ideal situation would still be to send it in a saline soaked gauze, probably in an ice pack. As soon as possible, that's the best we can do in our country.
Or for a distant place, you send the patient to
I guess. Send the whole patient.
I think with the advent of this muscle myositis antibodies, I think people getting a muscle biopsy, I feel definitely it is not a center of excellence to do the muscle biopsy immediately, having a cryo lab. I think that also the one area where people are avoiding a muscle biopsy. It's out of the session, but with the myositis specific antibody, there's nothing will be very clear it is an inflammatory myositis.
So you're very right in saying that, Dr. Pani, the number of muscle biopsies which any center is currently doing is coming down drastically. So it's far more easier to do a myoplot than do a muscle biopsy. And also even internationally, the indications for muscle biopsies are actually coming down.
MRI is available in all.
Yes.
Yes.
MRI and even ultrasound, like most of the rheumatology centers now are having ultrasound. So you can just see the ultrasound itself.
So people are moving to muscle biopsy when patient doesn't improve, because we have some cases having dysphenolopathy with an inflammatory disease. So when you have such setting, when they don't improve on treatment, and then follow up, you may need a muscle biopsy, definitely to show whether it is inflammatory or non-inflammatory.
Thank you, Dr. Pani.
Thank you.
Next we have, we will be moving on to biopsy before you start the immunosuppression, especially steroids, because they say that the cellular inflammation changes, and Dr. Anita Mahadevan says that if you've already given steroids for 2 weeks, then the pathology would have changed drastically, so there is no point in doing the muscle biopsy again. So Dr. Anita Mahadevan's 3 lectures on the interpretation of muscle pathology are also there on the IRA YouTube channels. Those of you are interested, please take a look at that.
Could be performed only in centers with established experience with surgical procedure, handling of large specimens and pathological technique. Otherwise, artifacts will be there. The exception is for diagnosis of vasculitis and neoplastic classic. Dural nerve is selected most commonly for biopsy. The resultant sense why? Because the resultant sensitivity is restricted to a small area of the heel and dorsolateral aspect of the foot, and its morphology has been well characterized in health and disease. Now with the structure of nerve, the outside there is epinucleum, inside there is nerve fascicles and vessels. Now vessels are surrounded by perineurium, and individual nerve fibers is surrounded by endoneurium. And this is a schematic diagram of the nerve fiber. It is surrounded by axons. The axon is surrounded by Schwann cells, that is myelinated nerve fiber. In a nerve, there is 2 types of fibers. One is myelinated, another is unmyelinated or non-myelinated nerve fiber. The non-myelinated nerve fibers are small fibers which cannot be seen in nerve biopsy. Skin biopsy is required for that. And the large fibers, that is myelinated fibers, can only be seen here. Among the large fibers, there are thickly myelinated or finely myelinated nerve fibers. Now this is sural nerve. There is two parts. One part is from tibial nerve and another is from peroneal nerve. The lateral sural and medial sural, and one is communicating branch. Communicating branch is there. This is the communicating branch. Finally, it descends down and behind the lateral malleolus. And the supply area of sural nerve. In the front view, this is the supply area of sural nerve, and from the back, this is the supply area of sural nerve. Now, indication of nerve biopsy, then definite diagnosis can be made in vasculitis, amyloidosis, sarcoidosis, Hansen's disease, and tumor infiltration. It may be supportive in CIDP and paraneoplastic neuropathies. Types of nerve biopsy, whole nerve biopsy and fascicular biopsy. Two types are there. Now, selection of nerve. In distal lower limbs, we usually select sural nerve, or most commonly biopsied nerve, and superficial peroneal nerve can also be taken. In proximal lower limb, the intermediate cutaneous nerve of the thigh or lateral cutaneous nerve of the thigh can be biopsied. In upper limb, superficial radial nerve or one of the antebrachial sensory nerve can be biopsied. Fascicular biopsy is from affected root or plexus. Now, combined nerve and muscle biopsy. Combined biopsy with nerve along with muscle helpful, particularly in vasculitis, sarcoidosis, and amyloidosis. Its help increases approximately 15% because the same pathology you can demonstrate in two types of tissues. Superficial peroneal nerve with peroneal brevis muscle within a same incision, and intermediate cutaneous nerve and thigh muscle can also be biopsied. Now, this is the supply area of the antebrachial nerves. This is lateral and this is medial. And this is the superficial peroneal nerve supply area. Superficial peroneal nerve and their supply area. This muscle nerve combined biopsy usually done in neurosurgery department. We are not doing it, but still one picture I have kept here. Incision is given 1 centimeter in front of a line of lateral malleolus and head of the fibula in the lower third of the leg. Here, both you can expose the muscle and the nerve, peroneal nerve and the peroneal brevis muscle. Here, peroneal brevis muscle and the nerve. In hand, we can take the radial sensory nerve. This is the radial sensory nerve. This can also be biopsied. Now, prerequisite is onset, routine blood test, and serology. The equipment is very simple, excluding that the dressing draping, lignocaine, syringe, and antiseptic solution, povidone and spirit. You need on the scalpel. Number 11 is suggested. I have done it with number 11 and the scalpel. Skin refractor, forceps, artery forceps, and suture and silk and skin cutting needle. Now this is the incision site for sural nerve biopsy. This is lateral malleolus, this is tendinoatrius, and this is the incision site. Now we show the video for sural nerve biopsy. To cut short then, I have shown the dressing draping portion and lignocaine infiltration portion. I just give the incision as shown. And after that, light dissection is needed with artery forceps. And nerve will automatically comes out with this. You can see the nerve.
Most important thing is that the position of your
Incision.
incision is correct,
Ah.
then the nerve just right there.
It just stays below skin. And this is your nerve.
Beautiful, hardly anything.
Actually, after giving lignocaine infiltration, there is hardly any bleeding. Should I continue this video or
Yes, sir.
stop?
Yes, sir.
Okay. That time skin detector was not there. I used artery forceps to detect the skin. But it doesn't matter. A slight dissection is required. Usually we tie two knots in two ends of the nerve and cut it distally. And nowadays pathologists don't prefer this tying of nerves.
How do you make sure that it is the nerve which you are touching?
Yes, I will tell. Then, not many structures are there, just little skin, ends may be there, one small segmental vein. You can palpate, it's a cord-like structure and color is different for vein. And if there is any doubt, we use one practical method. We try one to make it above and just make a small nick with the needle over it. If there is bleeding, it is well, otherwise it is not. But it is not required.
When you're handling the nerve, does the patient get any pain at that?
No, already I have given lignocaine infiltration.
So into the nerve as well.
The subcutaneous. No pain.
Some sort of paresthesia or something like that when you are handling that nerve, which can be proof of principle that you are actually.
After giving this type of infiltration, Usually patient doesn't complain in this type of things. Actually, that time I was alone. No second person was there. So everything I have to admit. Now finding troubleshooting, findings are now I have already discussed now, and simple dissection you can find the nerve if you give the proper incision, and facial nerve I have already also discussed that. Otherwise nothing else to be there. Now complications of nerve biopsy. Nerve biopsy is associated with as high as 15% complication. Minor wound infection, wound lesion, stump neuroma, unpleasant sensation. Original sensory deficit declined by 90% after 18 months. Complications are more in a smoker and lower the arterial insufficiency. Now, contraindication of nerve biopsy is arterial insufficiency in lower limb and any unusual skin coloration. Now, utility of nerve biopsy is essential for definitive diagnosis the cause of the neuropathy using diagnostic findings that will alter management is only 20%. That is vasculitis, sarcoidosis and leprosis. It is helpful in 20% and biopsy is not useful or not contributing more than 50%. From nerve biopsy, we can assess severity and activity of the disease. Now how to send biopsy? Ideal length of the nerve biopsy is at least 4 centimeters. The nerve is placed gently and secured with a pin at each end on a silicone pad in a dissecting dish or a wax plate for 15 minutes. It should be done in the place of biopsy. At least pathologists expect that. The nerve dissection is cut into 3 pieces. Proximal 1.5 centimeters. That is also important. That nerve should be placed such a way that you can identify proximal end and distal end. It is written on that plate. Because there are diseases which is length dependent. Proximal and distal difference may be there. Proximal 1.5 centimeter for the frozen section. Central 1.25 centimeter for the EM section, electromicroscopic section, semi-thin section and electromicroscopic section. Distal 1.25 centimeter for paraffin section and nerve teasing. Now semi-thin, ultra-thin and normal section, the measurement is around 5 micrometer is normally done. For amyloid it is propongolate, it is 8 to 10 and semi-thin is 1 and ultra-thin is 0.5. avoid pinching, crushing the nerve during procedure. Now vital ones should be remembered. They should be frozen without fixation. The frozen section should not be fixed beforehand. Vital 2 should be fixed in 3.9 or 4% glutaraldehyde. And vital 3 should be fixed in 10% buffer formalin. 3 types of vials are there. It is very vital. Now treatment of the nerve, biopsied nerve. 1.5 centimeter I have described. The neutral buffer formalin, this is for paraffin testing, hematocin eosin, modified tricho, pongorate can be done. 4% glutaraldehyde, 17 section, thin section for electromicroscopy, and toluidine blue or toluidine blue and basic fusion can be done here. And otherwise, isoprene as shown in previously in muscle biopsy, minus 180 degrees centigrade liquid nitrogen, poison section, hematocin eosin, modified tricho, and pongorate, and basic first violet. Stage can be done. Now staining, there are too many staining, but only the staining in our institute, HE staining, APAL for myelin, and toluidine blue staining, pongorate staining, and 5 Paraguay staining for leprobacilli. Now paraffin section, nerve is fixed in a natural buffer formalin solution, cut into 2 pieces, 1/3 for the transverse section and 2/3 for the longitudinal section. Sections are 5 micrometer except for pongorate staining, which is about 10 to 10, 8 to 10 micrometer. And stained with hematocin eosin, modified trichome or pongorate staining. Features to be described in report: number and shape of vesicles, and epinuria, neovascularization, vasculitis, location, type and caliber of the vessel involved, and cell types infiltrated, perinurium infiltration, endonurium, fiber loss, degree and symmetry of the loss, fiber types involved, acute axonal breakdown, myelin ovoids, degenerative clusters, skinny myelinated fibers, thinly myelinated fibers, onion bulbs, edema, sclerosis, inflammation, and vascular changes, that is amyloidism and microangiopathy. Now this is the normal sural nerve, stained after biopsy. This is epinuria, and these are the nerve vessels, perinurium, and these are vesicles. It is not HE and it is toluidine blue staining. This is myelin. Usually hematocin eosin, myelin is cannot be seen properly, but still it can be seen. This is myelin. This is a vessel, and these are the non-myelinated nerve fibers in the normal sural nerve. This is capal staining for myelin, and myelin can be visualized very well here. This is action within the myelin. It is thinly myelinated and small fiber, that is thinly myelinated and deeply myelinated fibers. Now interpretation. Interpretations are according to the disease I am saying. Now in vasculitis, intramural infiltration of the inflammatory cells and fibrinoid necrosis of the vessel wall observed in small arterioles and perineural and epineural spaces. Perivascular infiltration of the inflammatory nucleolar cells without intramural necrosis or cellular infiltration is an early and mild changes in vasculitis. In vasculitic neuropathies, axonal degeneration is the predominant finding. Thus, the diagnosis of probable vasculitis is made when perivascular infiltration of the inflammatory cells are present together with axonal degeneration. If the clinician findings are compatible with vasculitis, they usually rate probable vasculitis, not vasculitis. Directly they do not rate vasculitis. Central fascicular degeneration is typical for ischemic neuropathy and is seen in vasculitic neuropathy also. Vasculitic neuropathy diagnostic criteria: perivascular inflammation with active or chronic vessel damage, or perivascular inflammation in combination with one of the following histological features: vascular IgM complement or fibrin deposit by immunofluorescence, hemocyanin deposit, patchy multiple nerve fiber loss, or prominent axonal degeneration. Vascular neuropathy continue. The larger vessels usually involved in polyarteritis nodosa, Charles-Strauss syndrome, vaginal granulomatosis, and rheumatoid vasculitis, and smaller vessels are involved in Sjogren's syndrome. Now, vascular neuropathy, this is the vessel and infiltration of nuclear cells around the vessel. This is active one and this is inactive one. This is the vessel, and within the vessel there is complete occlusion of the lumen due to intimal thickening, and muscular layer is infiltrated with inflammatory cells. And in chronic one, there is lumen is either treated or non-treated. There is RBC, red blood cell, infiltratory cell, and thickening of the vessel wall. In comparison to this picture, the vessel wall is thickened. Now, CIDP, chronic idiopathic demyelinating polyneuropathy, is pathological hallmark is segmental demyelination, axonal degeneration, proliferation of the Schwann cells, that is onion bulb formation, and inflammatory infiltration, and endothelial edema and axonal shrinking of fibrosis. I have shown all the features in this slide. Here, the B is normal sural nerve. You can see the myelinated and non-myelinated fiber, how they are arranged. And here, you see the myelination is very less. Few myelinated nerve fibers and few are devoid of myelination. And some fibers have no axon also, where there is only deeply white inside. Axon loss is also there. Now, this is also slide for CIDP. In this picture, in the same patient, both are present. One is unmyelinated fiber, loss of myelination, and there is onion bulb formation. These are onion bulb formation. Later I will show you better in a slide. These are onion bulb formation. Usually simultaneously they are not present, but in exceptionally one patient, one side is there. These are onion bulb formation. All are onion bulb formation. And this is the axonal loss, and this is the infiltration of the inflammatory cells within the nerve. This is a transverse section. These are the diagnostic, the myelin digestion chambers. In transverse section, if you see this, it is the hallmark of axonal degeneration. And here you see the normally myelinated one and one that is thinly myelinated. It is the degeneration of the myelin, and here the onion bulb formation. Now here you can see the onion bulb formation. Better picture of onion bulb formation. Here is the edema. Subperitoneal edema is there. All are features of the CID. Now amyloid neuropathy. Now I see diagnostic test for choice in any suspected case of the amyloid neuropathy. The hallmark of amyloid neuropathy is amyloid in the nerve. Amyloid is histochemically converted positive and green by respiration, apple green actually by respiration after converted with polarized light. Three patterns of amyloid deposits are there in extra neural connective tissue, widespread deposit, and within the wall of the nervosum, both in perineurium and interneural spaces. Prominent nerve degeneration in amyloid neuropathy is axonal type, involving a small diameter of the nerves. This is a picture of comorbid positive amyloid, and this is the polarized like apple green bilateral. Now, sarcoid, the presence of non-degenerating granuloma in nerve is diagnostic of the sarcoid neuropathy. Sarcoid is diagnosed once leprosy has been ruled out by acid-fast bacilli stain. Sarcoid granuloma is classically a non-degenerating granuloma consisting of epithelioid cells, Langerhans cells, and lymphocytes. No organism are found in sarcoid granuloma. Otherwise, the granulomas cannot be differentiated easily. Non-degenerating granuloma has been observed primarily in the AP and perineurial spaces. This is a granuloma with lymphatic cell infiltrate. This is perineurium, and this also shows two granulomas. One is visible and another is here, and within it some giant cells is also visible. Now, leprosy, there are many types of leprosy is there, and the picture, pathological picture is also different types in different types of leprosy, but I have kept only lepromatous type, which is easily diagnosed and important for us. There is also granuloma, they are necrotizing or not, and there is foam cells in leprosy, foam cells. This is the arteriole, and around it foam cells are there, and white stain shows lepra bacilli. Now, malignant infiltration, abnormal malignant cells are visible here, so malignant infiltration can also be identified if the cells are present within the nerve. Now, diabetic neuropathy, usually we do not do biopsy in diabetes, but still if we have to do, the hallmark is again axonal degeneration, that is myelin digestion chambers are there, and there is changes in vessel, that is sclerotic vessels. Here there is no inflammatory issue, that is sclerotic vessels, and central degeneration of the axons are more in the fascicle, the central of the fascicle, because superficial portion can get nutrition from body fluid. And I gave this picture to show the teased nerve fiber. Teasing is separating the individual nerve fiber under microscope with the instrument, and it can be seen without stain or with silver stain, and for demyelination. This portion is demyelinated portion, and this is a node of Ranvier where it is demyelination is also present. Now, recent advances, immunohistochemistry and immunofluorescence usually not done in our center, and we usually not send the biopsy for that too. And neuronopathy, usually it is written in book that nerve biopsy's yield is very less, but nowadays some expert pathologists can opine with nerve biopsy that this is neuronopathy. This is I added recently after hearing one seminar in INK Kolkata. And this is the degenerating clusters. If the nerve body is damaged in neuropathy, these degenerating clusters will not be there. These degenerating clusters will not be there in neuropathy. But in neuropathy, degenerating clusters are there. There are 2 to 12 axons with thin myelin of similar type, or thin myelinated similar type of axon clusters. That is degenerative phase. Thank you.
Session is open for questions.
Partha has shown very beautifully the biopsy procedure, and it looks like very easy to do kind of procedure because the way you demonstrated it. That's very nice. In our center, we do our nerve biopsies, but sometimes we do send to plastic surgery people for doing the nerve biopsy. And whenever we are in doubt, we are also doing the composite peroneal nerve and the muscle biopsy. So that we find to be very useful when we are looking at both muscle disease as well as nerve disease. We are not able to clinically differentiate between the two. At the back.
So the crux is, unlike muscle biopsy, can we do it at a smaller center in terms of transportation and storage?
You can do it, but transport actually pathology people wants that you divide the nerve, you fix it and send it to them. They ask for it, but we have pathology department just outside our building, so we send it in normal saline or normal saline soap gauge. Even ice pack not required, within minutes it can be transported. If you have to send for 1 or 2 hours, you can use it with.
The purpose of this workshop was to make us more independent. So we've chosen procedures which we can do independently. So I think nerve biopsy is something which we can do independently. Maybe we can do couple or 1 or 2 in supervision with a plastic surgeon or an expert neurologist, and then we can start doing it on our own. It's not a very difficult procedure is what I have understood.
Not at all difficult.
Pardon me?
Not at all difficult.
Not at all.
What is the yield of getting a diagnosis with a pseudo biopsy?
Only 20%, sir.
So, what is your comment?
So we do nerve biopsy in situations like vasculitis, when you are banking on the nerve biopsy to provide you the diagnosis. But in vasculitis per se, if you look at, the yield is not such low like 20%. It is said to be somewhere between 40 to 60%. And in such situations, the diagnosis usually comes from the vessel which is there along with the nerve, rather than to some extent from the nerve, but also from the vessel which is taken along with the nerve.
And if that nerve is not affected,
Even if the sural nerve is unaffected, even in that situation, the biopsy yield is said to be as good as 40%, especially for pickup of vasculitis.
It's case specific.
fine,
Clinically,
if you are getting,
clinically indicated, then yield will be better.
it has got a very strong positive predictive value. What about negative? If it's not there, then
So vasculitis is a disease in which we need to access multiple areas to get a diagnosis, and to my mind tissue biopsy is one of the good ways forwards. Nerve biopsy gives us an opportunity to examine the pathology in a very easy manner. It's not a very difficult to do procedure, not very invasive compared to a lung biopsy or some other different biopsy. So I think it's something which we should all know and should be able to do it on the bedside. And its applicability has to be very judgmental depending on the patient which we are dealing with.
what is your experience
For
for vasculitis, diagnosis of vasculitis? How frequently do you need to do a nerve biopsy?
we do it whenever, we do it when we don't have diagnosis on serology like your AMA, and the skin biopsy has also failed to give the diagnosis. Only in that situations where the disease is predominantly limited to nerves, we can't do a kidney biopsy, we do use nerve biopsy. My personal problem is that we get usually patients who are referred from elsewhere and they would already be experienced with treatment. So the inflammation is usually not very intense in them. So what a pathologist reports is remote possibility of a vasculitis cannot be excluded. But it is a very useful procedure, I think.
And do you do rectal biopsy or only nerve most of the time?
If you're doing ourselves, we just do nerve biopsy. Yeah, we don't
And
do
the
the.
yield goes high if you do skin also along with that, and muscle also and nerve. And somewhere you can pick some vessel which shows inflammation.
You're right about that. But for that, we're not doing it ourselves. It's done by our plastic surgery.
We can ask that they can do muscle and skin also simultaneously.
Yes, if you're more comfortable with that, then why not?
And what do you think, how pragmatic we are in doing all these procedures in our center?
Pragmatic, what do you, I mean, I didn't understand.
Can you be doing all these things in an expert way? No, not the procedure itself. Because the plastic surgeon is tuned to do it. Surgeon is tuned to do it. We should be doing it ourselves, or like on this minor salivary gland biopsy is fine. A skin biopsy, much biopsy is fine. But when you go on to do a procedure like this, do you recommend that it should be done by a pathologist itself, or it should be, because to get a proper healing, proper nerve, a person who is well trained in that, that's my recommendation. How much should we extend ourselves? Because after all, everybody is MBBS. Everybody can go ahead and do anything what they like.
So, to the best of my understanding, the purpose of this workshop is to expand our capabilities, and we have personal, I've had personal situations where you refer the patient to a dermatologist for a skin biopsy. They delay it by 2 days. By then your lesions have disappeared or they have started fading, and then they will say that it is now fading lesion, we should wait for the next crop. Similarly, for the now biopsy, if you send it to a plastic surgeon, they want to wait for their OT, so which might again take a couple of days. So it's an unnecessary delay according to me. Muscle biopsy, of course, is very easy. It can be done as an outpatient procedure, and nobody actually wants to do muscle biopsy, neither the neurologist or the plastic surgeon. Minor salivary gland biopsy, I think it's a very OPD procedure, and we should be doing it ourselves. So this is an effort to make us more independent, if you get it what I'm saying. And legally, I don't think there is any issue if we are doing these kind of procedures.
My contention of sitting here is, I want to know what are the nuances of these procedures, so that when I am referring, I know that how precisely they are doing it. What's the problem? What are the problems which could be encountered? Rather than doing it myself.
Right.
That's my contention.
So many of our residents who are here, I think they all want to learn hands-on how
The residents are very, they want to do everything on their own.
So that's in a way good, because I think that if you're going to, as we are all being made to do rural bonds and all those kind of stuff, it is good if we all have hands, if we have experience, at least we have learned theoretically how to do it. And I know situations where people do surgeries based on YouTube videos. So, and these all of these videos, that's why we focus on videos in this session, so that experts can teach us how to, do these procedures, not just the YouTube videos, but if there are any troubleshooting, any questions, we can get them clarified right here. So if there are any questions pertaining to the nerve biopsy procedure, Dr. Partha is here to answer.
Thank you.
Thank you very much, Dr. Partha. Thank you very much for coming. Nerve biopsy is actually a very easy procedure. Next we move on to skin biopsy. For that we have Dr. Kunal Chandavar from Lucknow. He recently moved to SGPGI, is what I have understood. So let's see what he's trying to make it very exciting for us.
You go for immunofluorescence, you actually see the immune complex variety. What are the indications of skin biopsy? Now, skin in itself is the largest organ of the body. So there are innumerable indications, but whenever you are in doubt of a diagnosis, do a skin biopsy, and whenever you are suspecting something serious, do a skin biopsy. There are mainly 3 types of skin biopsies. One is the shave biopsy, one is the punch biopsy, one is the excisional biopsy. And depending on the depth of the lesion you are expecting it to be clinically, you do that biopsy. If you are suspecting that the lesion is just limited to the papillary dermis, you do a shave biopsy. If you think it is going till the subcutaneous tissue, you do the punch biopsy. And if you think it is deeper, go for an excisional biopsy. For most rheumatological indications, at least a punch biopsy is needed. For us, the shave biopsy indications are quite less. Then coming to contraindications. So actually there are few absolute contraindications to a punch biopsy. Neither anticoagulation nor severe thrombocytopenia is an absolute contraindication. However, to anticipate bleeding complications, it is important to determine whether the patient has a bleeding disorder or is taking any medications known to interfere with hemostasis, such as warfarin or aspirin. Any history of allergic reactions to local anesthetic, antiseptics, topical antibiotics, or adhesive tapes should alert the provider to seek alternative options. More often, the patient will report adverse reactions to epinephrine. So that is something, when you are giving lignocaine and epinephrine combined, more commonly the reaction is to the epinephrine than the lignocaine per se. So you can just use plain lignocaine on them, those who have bad reaction, and then see. Then a material required, so you need a skin preparation solution, that is either povidone iodine or chlorhexidine, and a clean towel or a drape, a local anesthetic, a 3 ml syringe, a 21 gauze needle for drawing up the anesthetic, and the smallest possible needle you have for injecting it. So you need to take it out from a different needle and inject it with a different needle. For the punch biopsy, you need a skin punch. It is available in various sizes, 2 to 8 mm. It is commercial. Even I think it is available up to 10 mm. You need for the shave biopsy, you need a flexible shave biopsy instrument, or simply if you have a double-sided razor blade that you use for a 15-number scalpel. You need forceps, scissors, gauze pack, non-absorbable sutures or adhesives, non-sterile gloves, small adhesive bandages, circular or square, and enough 10% formalin container for the number of biopsies you are going to do. I'll come to the punch biopsy first. This is the minimal instrument requirement that you need. You need the formalin container, the punch biopsy needles, forceps. If you are doing a large punch biopsy, you might need to suture it. Otherwise, there is no need of suturing. The needle with lignocaine in it. For draping, non-sterile gloves, and you might need a suture needle otherwise. Now steps. So the first step is obtaining consent. You need to prepare the skin, drape the skin, anesthetize, creating a wheel, place the punch over the lesion, and firmly but gently rotate the skin until there is a decrease in tension on the tissue. Once you will do it, you actually feel when it goes down that the tension reduces, and this indicates that you have got a full thickness sample. Remove the tissue gently with forceps on needles to minimize crush artifact, because if you press it too hardly, there will be a crush artifact that will be there. And the sample area is 4 mm or less. You may dab it with aluminum chloride solution or other hemostatic agents, or close with one suture. I have a sample for you all. This is how a punch biopsy needle looks like, and what you just need to do is you will have a prepared skin that is draped and anesthetized, and you just need to take it out, and you can do two things. You can either first mark the lesion by using the back end of the instrument, and then just have to put it inside and rotate it gently, and your biopsy will be done. I don't have a forceps. You can use a forceps and take out the specimen and put it inside the solution you're taking. So I have two fruits and two needles, and passing it on. You can all try it and have a feel of how to do a skin biopsy. I'm also giving you an option between an apple and a guava. So whichever you want, you can.
This is a disposable punch biopsy, which is we saw made in Chennai. It is only 100 or 150 rupees.
You just check for the sensitivity using a forceps whether the skin has attained proper anesthesia or not. And then you are using the needle, inserting it, and then you're rotating it smoothly. Sometimes the tissue is adherent, so you might need a scalpel to just remove it.
Does this come in different sizes?
Yeah, it comes in different sizes. So the standard one used is either 4 or 5 mm, but you can go smaller and larger based on whatever your requirement is. The maximum I think is 10 mm right now. Commercially up till 8 to available hai. I just checked it before coming. So, you keep the tissue in the corner something. Any
Questions? For DIF, you need to put it in normal setting.
I'll come to the fixators and detail of the procedure itself. If you perform, यानी आपने करके देखा है तो it becomes quite easy. It is not a very difficult procedure to do. So then coming to shave biopsies, you need to obtain consent, clean the skin and anesthetize it. There are two types. One is superficial shave for a macular or a raised non-suspicious lesion. You hold the blade parallel to the skin and shallowly remove the skin disc or the lesion itself if it is raised. And the other is saucerization. This is used for pigmented lesions. Most commonly it is used for melanoma diagnosis, not a lot of rheumatological indications per se. Measure 1 to 3 mm margin before shaving. Anesthetize, creating a wheel. Make the lesion easier to make the lesion easier to shave, and squeeze the skin between the thumb and the forefinger of the non-dominant hand to further elevate the skin. Hold the blade to a 45-degree angle to the skin, bend or bow the blade depending on the width of the lesion, and remove the disc of tissue well into the subcutaneous fat. Use a hemostatic agent or an electroporating and wipe clean. So there are two kinds of lesions. One is something that will be already raised, so you just have to pass your blade through it. It will come off easily. And something that if it is not raised and it is a suspicious lesion, you just curve your blade and then create a saucer shape, and then you can do the biopsy. So regarding complications, there are usually not very severe complications involved. Pain, if there is pain, it is generally insignificant. Infections do rarely occur. Excessive bleeding almost never occurs. If you have taken proper precautions, you would hardly ever find it. Scarring, there is always a possibility, and acne-like pockmark may be observed. Hypopigmentation may occur in the area. Some topical hemostatic agents may cause prolonged hyperpigmentation. So, and if you are sending the biopsy from not the right area, you might miss the diagnosis, and allergic reactions to topical antibiotics, anesthetics, dressings, and other agents. Now, so you have done the biopsy. How do you send it? So, sending the correct form is very important. Whenever you are doing a skin biopsy, you need to mention the demographics, the disease you are suspecting or the patient already has, the duration for which the patient has had those lesions, whether he has applied something additional on it. That might help the pathologist decipher if there are lesser changes and what you are suspecting, description, diameters of the lesion, and diagnosis that is suspected. This is just a crash course into how the skin lesions are described. There is a primary morphology, there is a secondary morphology, there is a size and shape, distribution, how it feels, and how whether it is well demarcated and not well demarcated. All these points will help you in reaching a final conclusive diagnosis to what the patient has. Now, talking about fixatives, so always use 10% buffered formalin to avoid artifacts such as corneal pigments in crystal formation. Fixation time is usually 1 to 2 hours per millimeter thickness of the specimen. Use glutaraldehyde for electron microscopy. Mischel's solution for direct immunofluorescence, if that is not available, normal saline is reasonable. Use adequate amounts. So the adequate amount usually is at least 8 times the volume of the sample. So that is the minimum that you need. When would you need unfixed fresh specimens? So for DIF, for immunoperoxidase staining, for monoclonal antibodies and enzyme studies, and even in case of gout and amyloid, you can send directly unfixed fresh specimens. This is in the normal saline flow itself. Then what are the important points regarding skin biopsies? So an ideal lesion for the biopsy should not have been scratched or traumatized or treated by topical or systemic therapies. Always take a deep, large biopsy, include subcutaneous tissue. Prefer excision biopsies for bullous lesion, paniculitis, granulomas and scleroderma. There is just a small cheat code if you don't want to go for an excision biopsy and have a punch biopsy. So we sometimes do a double punch biopsy. You take one punch, remove it and then go deeper to go into the deeper subcutaneous tissue. And that is how you might wiggle out of a possible excision biopsy if you want to do it by yourself. And for punch biopsies, usually a 4 mm punch is required for adequate histological studies. Avoid excoriated and secondarily infected lesions. The specimen should be handled gently and not to be handled with forceps except at the edges to avoid crush artifact. Where do you take the biopsy? So you resort to multiple biopsies from multiple sites in difficult to diagnose cases. If you have a suspected leprosy patient and there is no clear hypopigmented area, which is hypoanesthetic, you might see a few suspected sites and take a biopsy from it. Lesions can change with time. You might need to repeat biopsies in evolving lesions. Choose an early lesion biopsy in bullous disorders, ulcers, postural lesions, and suspected vasculitis patients. Choose an established and fully evolved lesions in patients with psoriasis, cutaneous lupus erythematosus, and leprosy. Include the surrounding skin for comparison in case of morphea and epiderma. Now, how do you take the appropriate skin lesion? So you use the most tender or the most reddish or the most purpurate site. You use the palpable purpura site for the biopsy of the lesion. In case of nodule, you biopsy the nodule. For a superficial ulcer, you biopsy the ulcer edge. For a deep punched out ulcer, you biopsy both the ulcer base and the edge. And for a livedoid racinosa, you biopsy the center of the livedo. For a bullous lesion, you biopsy the edge. Then appropriate timing. So if you are, you also need to mention the timing of the lesion when you are sending it for the report, because those lesions that are less than 24 hours might just have neutrophils and may not exhibit the classical fibrinoid necrosis that is seen in vasculitis. And those who are more than 48 hours might shift from neutrophilic to a lymphocytic morphology and leaving only evidence of fibrinoid necrosis. For palpable purpura up to mid-dermis, you need to go 4 mm or large punch biopsy, and for nodules and ulcers, you usually need an 8 to 10 mm punch or wedge biopsy with the subcutaneous tissue. Now regarding direct immunofluorescence, ideally direct immunofluorescence should be done on a lesion less than 24 hours old. The reason being that the inflammatory reaction secondary to the deposition of immunoglobulin quickly leads to the destruction of both the vessel wall and the immune complexes, so your IF report might be negative. The best specimen for DIF in a blistering skin lesion is the perilesional skin, and for the vasculitic lesion is from within the lesion. Biopsy sample must be submitted in normal saline and they must be processed within 24 hours. So this is regarding skin biopsy, and what is new in skin biopsy. So there is something called as this is tape strip biopsy. So they apply a tape, a circular tape, and this tape removes one layer of skin at a time. So, so the first layer of, when you apply a tape and you remove that tape, you have one layer of skin that is getting removed, and you can apply these multiple layers of tape for the amount of depth you want to go. The advantage of this process is you get, this is almost painless, and the sample you get from this set of biopsies you can use for mRNA synthesis and all the genomic and transcriptomic studies. I'm not sure this is you can do Western blot, RNA analysis, microscopy, mass spectroscopy, and all the new and shiny things. So I come to an end. So remember that any biopsy has 4 dimensions: length, breadth, depth, and time. The pathologist sees the first 3 dimensions. The clinical has the advantage to watch the 4th dimension, that is time, and only he can follow up the lesion. Hence, clinico-pathological correlation provides all the 4 dimensions. Thank you. This is, I think, not come to India yet, but this is done in Western centers.
So tape skin biopsy is something which will replace these invasive punch biopsies. Once we have the knowledge about transcriptomics and single sequence, which I'm hoping in the next 10 or 20 years will overtake many of the procedures which
It is that simple a procedure, even the patient can do it himself and send you the report in a leaflet per se. I think few people have put slow about it. Yes.
Can you biopsy your red hot ulcer with this?
Sir, ulcer, so if it is a superficial ulcer, you biopsy the edges, you can biopsy it through that. And if it is a deep ulcer, you are suspecting vasculitis, you are biopsy both the ulcer edge and the ulcer base and send it for biopsy.
there are no more questions.
Do we have, needle of different sizes? Suppose there is an ulcer.
Yes, sir, there are. So it is available from 2 mm to up till 8 mm. You can write, when you prescribe the punch biopsy needle to the patient to bring, you can prescribe whichever diameter you want. So if you think there is just a small purpura, you can even take a small needle and do it. If you want to have a large biopsy specimen, you can do it with a large punch biopsy. I'll share it, ma'am. Again, I couldn't do it myself, so I'll share it in the group or.
I'll send it across. Those who want any of these biopsy procedures videos, please let me know. Just send me or message me or numbers. I'll share.
Yeah. The other reason I didn't, because in rheumatology you would rarely do it per se.
Thank you, Dr. Very nice. So last we have kidney biopsy, Dr. Shankar from PGI Chandigarh.
And the contraindications, what are the various instruments that we need, and the procedure per se, various steps in the procedure, and a few small videos on the procedure, then the complications, and then I'll be showing certain photomicrographs of the renal pathology just to understand with respect to the rheumatological diseases only. So, as we know, biopsy of any organ is the gold standard diagnostic procedure for establishing a diagnosis, and kidney biopsy is a very safe procedure with minor complications seen up to 10% and major complications reported to less than 2%. And death has rarely been reported, even though in our center we do see death quite maybe once every 2 to 3 years, but it's very rarely reported post-renal biopsy. So coming to the indications for renal biopsy, these are the non-specific indications for a nephrologist. Any unexplained renal failure, whether it is an acute onset or a rapidly progressive renal failure, or sometimes in an unexplained chronic kidney disease also they may attempt a renal biopsy to establish the diagnosis. Then nephrotic syndrome, especially in adults and in children if they are not responding properly to therapy. Then isolated non-nephrotic proteinuria or isolated glomerular hematuria. These are the routine indications for renal biopsy. Then in post-transplant, either to when they are suspecting rejection or a dysfunction of the transplant kidney. Then renal involvement in systemic diseases. This is what is important for us as a rheumatologist. Any connective tissue disorder, whether it is SLE, ankylosing or any kind of small or medium vessel vasculitis, anti-GBM disease, primary Sjogren's or scleroderma with renal involvement, and when we are suspecting secondary amyloidosis in patients with long-standing inflammatory states. And sometimes the nephrologist may do renal biopsies in patients with renal masses, either a primary renal mass or a secondary infiltrative renal mass. So apart from this, there are the other indication that we need to remember is the prognostic value of kidney biopsy. Sometimes even though we are sure that the patient is having, say, per se SLE, still we might end up doing biopsy because we need to know the prognosis of the patient and to determine the class of the lupus nephritis. And the same holds true for ANCA vasculitis. There is a Burden's classification of ANCA-associated lumbar nephritis. I'll be showing those pictures later on. So even though here we don't do the biopsy for establishing the diagnosis, but to prognosticate the patient and to see the treatment response, we need to perform a renal biopsy. And also to see the activity and chronicity state of the kidney disease, especially in those patients who are unresponsive to the standard therapy or if they are having a relapse after attaining an initial remission. So this holds true mainly for the lupus nephritis. So the main absolute contraindications are any bleeding diathesis, whether there is thrombocytopenia, coagulopathy of any cause. We cannot perform a renal biopsy. If there is uncontrolled severe hypertension, what is cutoff defined is more than 150 by 95, but we usually try to control it to less than 140 by 90 in our day-to-day practice. And obviously, if the patient is not willing, never force the patient to undergo biopsy. Certain relative contraindications are there. Small size kidneys as such are not a contraindication, but if we are suspecting a chronic pathology, then there is no much yield in doing biopsies in small size kidneys. Then solitary native kidney, again very problematic if the patient develops any complication. Leading on to nephrectomy, then the patient would be on dialysis lifelong. Then severe azotemia can have bleeding manifestations post-biopsy. So to overcome this, the nephrologist usually perform dialysis one day prior to the kidney biopsy. Then anatomical abnormalities of the kidney, urinary tract infections, severe sepsis with systemic spread of sepsis. Then patients on anticoagulations or antiplatelets in the last 1 or 2 days before the procedure. And pregnancy, these are all related contraindications for doing a biopsy. There are certain prerequisites before doing a biopsy. As I already told, the blood pressure has to be controlled, even though the recommendation is that the diastolic BP has to be less than 95, but practically we do only after it is less than 90. Then we should have a normal sized unobstructed kidneys on ultrasonography. Then we should have a sterile urine culture before the biopsy. And the platelet counts should be usually more than 1 lakh. But at our center we do it at values more than 75,000 also with proper precautions. Then there should not be any coagulopathy. Then regarding the discontinuation of various antiplatelets and anticoagulants, the antiplatelet drugs have to be discontinued 7 to 10 days before the procedure. And oral anticoagulants ideally have to be stopped 5 days before the procedure and have to be shifted onto subcutaneous either unfractionated or low molecular weight heparin. And these have to be stopped at least 24 hours before the procedure. And post-procedure, you can start these anticoagulations after 24 to 48 hours after the procedure, if there are no complications. So again, this is the most important. I think this holds true for any biopsy. We have seen multiple biopsies since morning. So for every procedure, written informed consent is a must. We should never forget to obtain a consent because it will help us in if there is any legal issues in future. So there are various components of a properly obtained informed consent. So the most important is that what is the name of the procedure that we are going to perform in this patient, and we should explain the patient why this procedure is needed. And also we should document what are the benefits of undergoing this procedure and what are the potential risks and complications that are anticipated and how we are going to manage those complications if they arise. And the most important thing is what are the alternatives for this procedure. So we should always explain this patient whether there are any other alternative methods for this procedure and if they are willing to choose those alternative procedures. And this has to be explained in the language that is understandable by the patient, and time and date of obtaining the consent should be always mentioned. Because many a times patient, one person might give a consent today, and if we delay the procedure and the second day some other person might come and say this consent was not obtained properly and whatever. So time and date of obtaining the consent is preferably on the same day just before doing the procedure. So coming to the instrument procedure per se, these are the various instruments that we need to perform a procedure. So there are automatic and semi-automatic spring-loaded biopsy needles of various sizes, 14, 16 and 18 gauge. Most commonly used is a 16 gauge needle. It has been shown that it has the least complications and good amount of tissue comes with 16 gauge needle. And the length of the needle should be either 15 or 19 centimeters, and the penetration depth of the needle should be 22 millimeters. And it should have a sample notch of 13 to 18 millimeters. So I'll be showing a closer picture later on regarding the sample notch and penetration depth. Then the other instruments are the sterile gloves and drapes, lignocaine, local anesthetic, that is 2% lignocaine. Then povidone iodine to anesthetize the clean the local site, and ultrasound machine with a convex array and high resolution Doppler probe. So these are the barred kidney biopsy needles. This one is the automatic needle. This is the semi-automatic needle. So in the automatic needle, this is commonly used, and as you can see, there are two push buttons here. These two buttons, one is for the inside needle, which is inner needle, which has the groove for the tissue, and one is for the outer needle, outer sheath of the needle, and we have to fire the gun. We have to load the gun first. Loading means pressing both these push buttons down. So once you load this gun, to load this gun, you have to push both these buttons down. And once you insert the needle into the near the kidney tissue, then you fire the gun by pressing a button over the this end of the biopsy needle. So this is all automatic, and it's very simple to use. Just load this gun by pushing these two buttons and fire it by pushing it from the top. So then coming to the position of the patient, it is usually it has to be done in a prone position with a pillow placed under the abdomen at the level of the umbilicus, just to straighten out the back and spin the kidney so that there is not much of movement later on. So this is a picture showing the position of the patient to undergo biopsy. So as you can see, there is a small pillow which is placed under the abdomen so that the back is straightened. So then we identify and mark the lower pole of the kidney by using the ultrasound probe. Preferably the left side kidney is chosen unless there is any contraindication, like the left side kidney is structurally abnormal, then we will choose the right side kidney. Then we sterilize the skin and cover it with a sterile tray. So this is how we sterilize. Center to out technique is used. This holds true for any procedure. We have to start from the center and then clean it out first. So then we let the powder and iron solution to dry. Then we infiltrate 2% lidocaine at the entry point that we have already marked by doing the ultrasound before the sterilization. So we have marked the site and we are injecting the local anesthetic at the entry point. Some people might give a small nick at the entry point just to facilitate the entry of the biopsy needle, but it is not routinely used at our center. So So then we cover the ultrasound probe with a sterile sheet and apply a sterile jelly over it so that the cleaned area is not infected by the ultrasound probe. Then as I already told you, we have to load the gun and keep it ready before we enter the needle. So this is how we load. These two buttons are pushed back, so this is when the gun is loaded. So once you are inside, once you reach the kidney surface, then we fire it by pressing it from the top. So then again, after loading the gun, we again confirm the kidney side by doing the using the ultrasound probe. And this is how the kidney looks in the ultrasound machine. So we should identify the lower pole of the kidney. Ideally, the biopsy is taken from the lower pole. Then this is the angle with which the probe has to be inserted into the towards the kidney. There should be an angle of around 70 to 90 degrees. Some people go at 90 degrees, some people go at 70 to 80 degrees of inclination towards the surface. So with that 70 to 80 degrees inclination, we reach the lower pole of the kidney. So this is the corresponding ultrasound image where we can see this is the kidney parenchyma. This outer part is the cortex, inner part is the medulla, and inside is the collecting system. So this is the skin, and as you can see, there is an echogenic structure going on from the skin towards the kidney. And this is the biopsy needle which has been inserted up till the capsular surface of the kidney. So what happens in the capsular surface is we insert the needle up till the surface of the kidney. So once we fire the gun, the inner needle, which has a groove to collect the sample, initially it goes into the kidney tissue. Then the outer sheet will also cover this so that the tissue is entrapped within this groove, and then we remove the needle. So once we remove the needle and the outer sheet is again removed, then we have a 18 to 22 millimeters length of kidney sample in this groove, and this would be taken out and processed further. So this is just a video of the procedure. So this is how. So this is the angle at which we are going to enter. So then we visualize within the monitor. Then as you can see, the needle is entering in the subcutaneous tissue and reaching up to the kidney. So once you reach the surface of the kidney, then we should ask the patient to hold their breath for a few seconds. So this will prevent the movement of the kidney due to the respiration. So once the patient holds his breath, then we fire the biopsy gun. So I think I can play the video again so that we can. As you can see now, the kidney is moving with the respiration. So this has to be negated by asking the patient to hold his breath while they are firing. So once you reach the surface of the kidney, then you ask the patient to hold the breath and then you fire it. So then once the sample is obtained, ideally 2 courses are taken. Sometimes if the sample is in liquid, then 3 or 4 firings are done. But ideally it should be, we should try to avoid many fires because the bleeding risk is higher if there is more number of firing. Then it should contain both the cortex and medulla of the kidney. And for the naked eye, this is how the cortex looks. You can still identify certain globular kind of structures here. Then this is how the medulla looks. So this is much more congested and more blood vessels within the medulla. So if you are obtaining only one course, this is how the sample is divided for various tests. Most important are the light microscopy and the immunofluorescence, and wherever there is a provision for electron microscopy, the sample has to be sent for that. So if there are 2 cores, then in the first core, more amount of tissue is sent to the light microscopy and small amount to the immunofluorescence, and in the second port more tissue is sent to the immunofluorescence and small tissue for the light microscopy. And for transporting the sample, for light microscopy it is 10% neutral buffered formalin or Boyne's medium, and for immunofluorescence it is a Michel's medium, as we have already seen before, and for electron microscopy it is 2 to 3% glutaraldehyde. So if you are unable to, if you have only one sample, and always try to send the sample in a Michel's medium, because this can be later on used for light microscopy and also electron microscopy. But if you are having only formalin, still you can send it only in formalin. In experienced centers, they can process this formalin fixed tissue and use it for immunofluorescence and electron microscopy, even though the results might not be as good as sending in the proper medium. So post-biopsy monitoring, immediately the pressure bandage is applied at the biopsy site, and the patient has to be supine for next 6 to 8 hours without movement. And after 6 to 8 hours, the patient can roll within the bed, and up to 12 hours has to be confined to the bed. Then vitals are to be monitored every 15 minutes for the first 1 hour. Then every 30 minutes up to the 6 hours of post-biopsy. Then hourly to 2 hourly, depending on the status of the patient, for up to 12 hours. Then if the patient is suspected to have some bleeding, internal bleeding, then abdominal girth measurement becomes very important. So this is a list of complications that we can anticipate. Bell aching pain is very common. Some series have reported seen up to more than 50% of the patients. And presence of hematoma post-biopsy is up to 75%. So there will be some amount of hematoma post-biopsy. So no need of worrying for some amount of hematoma after biopsy. So routinely post-biopsy ultrasounds are not recommended to be done to monitor for the presence of hematoma. However, large hematomas are rarer, less than 5%, and subcapsular bleed, which can result in page kidney, that is compressed cortex of the kidney, is seen in less than 1%. Retroperitoneal bleeds less than 10%. Then microscopic hematuria seen in more than 90%. So few people usually say presence of microscopic hematuria post-biopsy is a sure short sign that you have properly taken a biopsy. Because if you have taken a proper kidney tissue, then there should be some amount of microscopic hematuria. But gross hematuria, even though some studies have shared 40 to 50%, usually it is about 5 to 10%. Then arteriovenous fistulas can form in less than 5%. Blood transfusion requirement can be seen in up to 8% of kidney biopsies. However, active bleeding requiring blood transfusions are less than 1%, and active bleeding requiring interventions are somewhere around 0.7 to 2%. And death, as I've already told, is less than 0.1%. And biopsy site infections are very rare. I could just find one study which said less than 5%, but not much data is available. So when do we say it is adequate biopsy? At least 10 to 15 glomeruli should be present, because as you can see in this table, when we are having only 10 glomeruli, there is a 35% chance that we might miss focal lesions. And if the glomeruli are up to 25, then the chance reduces to 5%. So ideally 10 to 15 is what we take as adequate number of adequate biopsy. So next, coming to the various terminologies that we see in our kidney biopsy report. So I am not going into the details of how the tissue is fixed and how it is processed in the lab, because that is not in our domain. So coming to the various terminology that we see in the reports, on the light microscopy we see the terms focal and diffuse. We need to understand what is focal and diffuse mean. Focal is in the entire biopsy. If less than 50% of the glomeruli in the entire biopsy are involved, we say it is focal. If more than 50% of the entire glomeruli in the biopsy are involved, we say it is diffuse. And segmental and global pertains to the single glomerulus. So if in one glomerulus, if the involvement is only part of the glomerulus involved, then we say segmental. So in one biopsy there can be segmental involvement with diffuse involvement. So almost more than 50% of the glomeruli are involved with segmental involvement within a glomerulus. So it could be segmental and diffuse. And global is when the entire glomerulus is involved, one particular glomerulus. So there can be focal with global involvement. So less than 50% of the glomeruli are involved, but all the glomeruli are diffusely involved. So this combination of terms can be there. So these are the pictures showing differentiating between focal and diffuse. As you can see in this picture, only these 3 glomeruli are involved and rest of the glomeruli are normal appearing. So this is less than 50% of the entire glomeruli in this tissue. So this will be labeled as a focal involvement. Compared to this biopsy where, as you can see, 5 glomeruli are involved and all the 5 are appears to be sclerosed. So all the 5 are involved. So this is 5 out of 5 are involved. This is the diffuse involvement. And this is a picture showing global versus segmental. This is a global involvement as the entire glomerular capillary loop is involved. Compared to this where it is only a segmental, like part of the glomerular loop is involved. So this is a segmental involvement. So these are the various terms that we see in biopsy reports of lupus nephritis. Mesangial hypercellularity, endocapillary hypercellularity, extracapillary hypercellularity, and fibrinoid necrosis. So mesangial hypercellularity is when the mesangium is containing more than 4 nuclei in the mesangium. Usually in the mesangium we only see 1 or 2 nuclei, mesangial cells. But if there are more than 4 nuclei, either it is mesangial cells or inflammatory cells which are infiltrating into the mesangium, then we say mesangial hypercellularity. Then endocapillary hypercellularity, when there is increased number of cells within the capillary loops that is internal to the glomerular basement membrane, and these cells can be either leukocytes or endothelial cells or the mesangial cells. And extracapillary hypercellularity is when there is increased cells within the Bowman space that is outside the glomerular basement membrane, and it could be these can be arising from the parietal or the visceral epithelial cells or the inflammatory cells that are infiltrating in the Bowman space. Then fibrinoid necrosis is when there is lytic destruction of the cells and matrix with deposition of acidophilic fibrin-rich material. So in subsequent slides I am going to show the pictures related to this. So this picture is showing the mesangial hypercellularity. Just for comparison I just put a normal glomerulus here. So as you can see this is a mesangial area, and compared to this normal glomerulus you can hardly appreciate the mesangium over here. These are the capillary loops lined by the endothelial cells, and this is one loop, this is the second loop, and this is the third loop. So in between these 3 loops you can hardly see 1 or 2 cells. This is the mesangium. So compared to this picture here, this is the capillary loop, this is the capillary loop. So in between, as you can see here, there are almost 7 or 8 nuclei which are same. So this is labeled as mesangial hypercellularity. So next coming to endocapillary hypercellularity, as you can see these are the endothelial cells which are occluding the entire glomerular loops. So and the number of nuclei you can see within the glomeruli is also increased. Usually one loop you can appreciate only 1 nuclei within 1 loop usually in the cuts. So here you can see that multiple nuclei are seen within the loop. So this is endocapillary hypercellularity. Here along with the endothelial cell proliferation there is also certain neutrophils which are infiltrated into the capillary layer. So this is hypercellularity secondary to both endothelial proliferation and inflammatory infiltrates. So extracapillary hypercellularity, we usually see the word crescent. So all the crescents fall into the extracellular hypercellularity domain. So crescents can be of various stages. Acute will be like fresh crescents will be either cellular or fibrocellular, and old crescents would be fibrous crescents. So cellular crescents are when the more than 75% of the crescent is consisting of either cells or fibrin, and less than 25% is the fibrous tissue. Fibrocellular is between 25% to 75% of cells present, and fibrous crescent is when more than 75% is the fibrous tissue. So these are the representative images to differentiate the 3. Then this is the picture showing the fibrinoid necrosis. As you can see, there is the acidophilic material without much cells in this. So this is the area where there is fibrinoid necrosis. Then the other terms that we see are the basement membrane thickening. As you can see here, the basement membrane is very clearly visible. If you can remember the normal glomerulus that I have shown there, we can hardly appreciate the basement membrane, but here you can see this basement membrane is very clearly visible. So these are the pictures showing basement membrane thickening. Then glomerulosclerosis. This is again segmental glomerulosclerosis, and this is a diffuse glomerulosclerosis. Then amyloidosis. This is how it looks on HLD staining, and this is a negative birefringence apple green staining of the amyloid. So these are all for the light microscopy. Then the special stain, that is the immunofluorescence. As far as we are concerned, we can divide them into immune complex mediated diseases and post-immune diseases. So immune complexes related would be mostly SLA, that is what we see. And apart from that, other rarely can be seen in other connective tissue diseases also. And post-immune disease is mainly the ANCA-vasculitis. So depending on the area which is involved, like pattern of involvement, it is either linear involvement or a granular involvement. So here this is a picture showing the linear involvement in the mesangium, in the capillary loop, while this is a granular involvement. So if you can compare here, you can see that the deposits are looking like there are multiple dots which are superimposed on one top of the other. Compared to this, where there is a uniform sheet-like deposition in the capillary, around the capillary loop. So this is when we say there is linear deposits, and this is when we say there is granular deposits. So then the next thing that we see is where are these deposits, so the location of the deposits, whether it is around the capillary loop as you can see here, or within the mesangium. So here you can make out the various capillary loops, and surrounding these loops there is a immunofluorescence deposition. Whereas in the mesangium, here it is there in the mesangium. Then again, depending on the location, whether it is glomerular basement membrane or certain diseases can have tubular basement membrane deposition also. So this is a linear deposition around the glomerular basement membrane. This is a characteristic finding in the anti-GBM disease. Then the other term that we see is a full house pattern. This is in the lupus kidneys. So full house is when we have all these 5 stainings positive, that is for IgG, IgA, IgM, C3 and C1q. When all these 5 markers are positive on a biopsy, then we say it is a full house pattern. Then this is a representative image for the post-immune, as you can hardly appreciate any immune complex deposits here compared to the various pictures that are shown. So these are characteristic of the ANCA-associated vasculitis. So apart from the glomerular changes, we also need to note the tubular interstitial changes, because this is important because many a times the outcome of the renal outcome depends on the tubular interstitial changes and not on the glomerular disease alone. And also certain diseases like Sjogren's can have a lot of tubular interstitial involvement with very less of glomerular involvement. Then again, the other involvement, the vascular involvement, can also help in predicting the outcome of the patients. Many times we miss these vascular changes and we keep treating them with immunosuppressants, and actually more specific therapy for the vascular changes required. Then podocyte changes can also be studied. So coming to the interstitial changes, this is a representative photomicrograph of the tubular interstitial inflammation. These are the tubules. This is the glomerulus and these are the tubules, and in between the tubules you can see that there is a lot of inflammatory infiltrate. So this is when we say there is tubular interstitial inflammation, and this is a marker of active disease. And this is compared this in contrast, this is a tubular atrophy, where you see that there is a lot of fibrous tissue being deposited within the between the tubules, and this is a marker of chronicity. So many a times in the biopsy we see IFRA scoring, IFRA 5%, IFRA 10%. So IFRA stands for interstitial fibrosis and tubular atrophy. So these are markers of chronicity in lupus nephritis. Whereas tubular interstitial active inflammation is obviously a marker of activity. So coming to the vascular changes, these are the micro representative photos from the scleroderma renal crisis biopsies. So this is an arteriole, where you can see there is occlusion of the arteriole mainly by the thickening of the intimal layer, very small lumen. And this is on chronic, this thing what we typically say as onion peeling appearance of the arteriole. So these are present in a patient of scleroderma patient, and these are indicative of scleroderma rheumatology. And these are the changes for thrombotic microangiopathy. These are commonly seen in patients with lupus, especially if they are APLA positive. So there is a fibrinoid necrosis of the arterioles, and also there could be fibrin deposition within the vascular pole of the glomerulus. So these all changes becomes important because if there is evidence of thrombotic microangiopathy and probably and if these are acute, then we need to institute plasma therapy, plasma exchange for these patients to reverse these changes apart from the immunosuppression. So vasculitis on kidney biopsy is not very commonly seen, but rarely we can see vasculitis changes in the biopsy. So this is a vessel wall which is showing break in the internal elastic lamina. So this blackish greyish structure is the internal elastic lamina. As you can see, there is a break over this area, and there is extravasation of RBC into the surrounding tissue. So many a times we don't see vasculitis demonstrated in ankylosing or any other vasculitis renal biopsies, but rarely we can find them. So to study the podocytes, electron microscopy is required. Just one last thing. So these are the podocytes, these are normal structure of the podocyte, and they may be effaced in podocytopathy. These can be encountered in patients with lupus. So just a revision of I think most of us know this classification, the 2018 revised classification for lupus nephritis. Then this is the burdens classification for ankylosing. They are divided into 4 classes: focal, crescentic, sclerotic, and mixed. So this has a prognostic value. So just to conclude, renal biopsy is a gold standard procedure to establish diagnosis in patients with renal involvement, and the risk of major complications is less than 2.5%. Written informed consent is a must before the procedure, and at least 10 to 15 glomeruli should be present for satisfactory reporting of the biopsy. And light microscopy, direct immunofluorescence, and electron microscopy helps in establishing diagnosis in 80 to 85% of these patients.
If there are any questions related to the procedure, yeah, please.
This fibrinoid necrosis, is it always a hallmark of vasculitis or non-inflammatory like DNA is also looked at?
It can be not always in vasculitis, but if there is a necrosis of the mesangium and the surrounding tissues, you can have fibrinoid. It can be seen in lupus nephritis as well.
But until unless vessel is involved, means in lupus if fibrinoid necrosis is present, what is it telling us? It is secondary vasculitis.
No. It can be, without vasculitis also there can be fibrinoid necrosis.
And once you have this, like on VIF, you have full house, and when you treat patient, in future, what will happen to this immunofluorescence? Like if
It
I
has to
treat after
reverse. If the patient is responding to therapy, all these changes have to reverse. That is why we said that biopsy have to be done, as we were discussing before also. Even before instituting immunosuppression, we have to do any of the biopsies because the steroids and other things can change the picture. But in renal biopsy, we can do it within first 1 month of giving immunosuppression. So we should never delay the treatment just because we need to do a biopsy. Because the aim is to save the kidney. So there is a delay in doing the procedure, always institute the therapy. And within first 1 to 2 weeks, you can still go for biopsy. So up to 1 month, the changes are not so dramatic.
Subcapsular bleed, is that a very hazardous kind of complication? Is there any care or caution per procedurally that we can practice in order to avoid?
I think, as I already told, screening for bleeding diastasis, any bleeding time, clotting time before doing the procedure if they are normal. And I think the patient also should be well informed about the procedure and how, like, they have to hold their breath while the gun is being fired. So I think most of the bleeding complications happen when the patient is not able to hold the breath and we fire the gun when the kidney is moving. So there will be the chance that there will be laceration small or big, depending on at what speed the kidney is moving at that time. So if the patient is well informed and the patient is cooperative enough and if the patient is able to hold breath for 2 or 3 seconds, then the bleeding risk would be much lower.
In children, in children you ought to give them general anesthesia so that they can hold their breath.
Sir, I am not sure about the pediatrics, but I think they do under general anesthesia pediatrics because
they use short anesthesia,
Short anesthesia.
because it's just a procedure which lasts few seconds. So normally the pediatric nephrologist they do it under short anesthesia. But if it is a little older child who is able to understand like 7 or 8 years or older, then they will do it
Holding
without.
breath is a bit difficult part.
yes, sir, because for children,
Key area.
that is why most of the procedures for children are done under GS. So I think
Short anesthesia.
short,
not full
short.
GA.
When this was not available, we used to do with Bill Silverman kidney biopsy. And that was like an audio.
No, I think personally I have not done kidney biopsy, but at our center the nephrologist does. So, but there are many centers where the rheumatologist does. I think I was speaking to Dr. Fani in the morning, so they are doing, rheumatologists are doing kidney biopsies there.
We used to do when we were MD medicine students.
Yes, sir.
So
And many centers, the MD post MBBS only do the biopsy, so I don't think there should be any legal complications.
radiologists are doing it wonderfully.
So any MBBS passed graduate is allowed to do any of the
Any
procedures
procedures.
in our country. It doesn't
So-
need to be a specialized technology or anything like that. So even like if supposing there is a, let's say, an appendectomy, that can be done by any MBBS doctor. So this is much smaller than that.
So that's why actually if we take a written informed consent which is properly documented, then I think we can avoid most of the legal complications. So that is why I wanted to kept one slide as well specifically for the
And there are nephrologists are not available in remote areas. We should be well equipped. I mean, any MBBS graduate should be able to do these procedures.
As an adult rheumatologist, we don't do, but our pediatric rheumatologist colleagues in our center, they do the biopsies on them.
Ultrasound and this crooked needle, they had made the major difference.
Yes.
Absolutely.
These two have made.
CT guided can also be done. It is mainly done by the intervention radiologist at our center. Those we usually do when the nephrologists are not convinced enough to get a biopsy when the borderline kidney size is there. So.
I think we can close this session now, and I think we had a wonderful Q&A session, and that's the most important part of any workshop. So thank you all the participants very much for your